Thank you, ma'am.
You can put on your video. Yes. Hi, Meena.
Good evening, madam.
Good evening.
Thank
Good evening.
you.
I think, Bhavna, we can start. Dr. Umayyan, hi. I can see she has joined. Yeah. Hello.
Sure, ma'am.
Madam, good evening.
Good evening. Good evening.
Madam, hello.
Can you hear us? Umayyan, can you hear us?
Yeah, madam. I'm able to see you, madam. Can you see me, madam? I am in a place where the network is not working properly. So I just, can you see me,
Yes,
madam?
yes. We can see you and we can hear you well.
Okay, madam.
Yeah.
Good evening, Parag Beniwale Saab.
Hello, Maya.
Hello, sir. Hello, Dr. Ashok Kumar, sir.
Yes.
Yes, sir. I am in a place where
hello,
the network is not
namaskar.
coming.
Yeah.
Namaskar, sir. Namaskar. Hello, sir. Hello, madam.
Ma'am, we are live now. Shall we start the meeting?
Yeah.
So, good evening, respected faculties. I, Bhavna, on behalf of Corona Remedies, welcome you all for today's Core Connect webinar with AMOGS Medical Disorder Committee along with Tamil Nadu OG Societies. Now, I request you all the honorable dignitaries present over here in the webinar to proceed for the lighting of the lamps and start the session with a small prayer.
Yes, we can start. Sir, namaskar. Dr. Pardesi sir has joined.
Namaskar.
Namaskar. We can start now. Yes, Bhavna, you can start.
Yes, ma'am.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Now, I request Dr. Shobna to please take over the session.
Good evening, everyone here, all the esteemed faculties. Successful and unsuccessful people do not vary greatly in their abilities, but they vary in their desires to reach their potential. Now, let us all join with all the success we have joined for this wonderful webinar, academic webinar. I now take the immense pleasure to welcome Dr. Sneha Bure, ma'am, who is the Managing Director for Sukarta Hospital, Maternity Surgical Nursing Home, and Laparoscopy and Infertility Center. She is the current chairperson for Medical Disorders Committee, AMOGS 2022 to 2024.
I think that should suffice. I just, because Dr. Pardesi has to go fast for his work back, I've just requested him. So I just take this opportunity to wish all of you a very good evening. Respected Dr. Rajendra Singh Pardesi, the AMOGS President, Madam Sujata Darvi, Secretary of AMOGS, dear friend Dr. Lakshmi Shrikhande, who is at present in UK, and so she's unable to join as chief guest. Dr. Parag Biniwale, our dear friend who is the Vice Chair of ICUG, and the guest of honor, Dr. Ashok Kumar, the Secretary of ICUG. All the esteemed faculties, Dr. Sheila Mane, Dr. Shashi Kabra, and also the moderator and my dear friend, Dr. Charmila Ayahu, all the chairpersons, Dr. Chanchal, Dr. Supriya Chiddarwar, the panelists, even the Dr. Umayal and Dr. Erod, Bhuneshwari, all the panelists from all across Tamil Nadu societies, I welcome all of you, and I take this opportunity to thank all of you for being with us for this program. I invite our president of AMOGS, who is going to guide us and bless us for this program. Sir is the president of AMOGS, and he's the past vice president of FOXI. He was the chairperson of Food and Drugs Medical Surgical Equipment Committee, and sir has more than 28 papers and more publications. So over to you, Dr. Pardesi, for your blessings.
Good evening, everybody. Respected Chief Guest, Dr. Lakshmi Shrikhande, Dr. Parag Biniwale, Dr. Ashok Kumar, and all societies. It's really nice to see AMOGS and Tamil Nadu societies jointly taken over this initiative of PPH. As all knows, PPH is a major contributor of maternal mortality, and really it's a divine work. Respect and the participants in this, the main are Dr. Chamila, Dr. Sheila Mane. Sheila Mane is PPH lady, you can say, Dr. Umayal Murugesan, Dr. Shashikala Kabra, and all panelists and chairpersons. I think this will be a great webinar. I wish every success to this webinar. I wish every success to Dr. Sneha Bhoyar for her future endeavor in FOXI as Vice President. I wish every success to Dr. Umayal Murugesan for her future endeavor in FOXI as Chairperson. Thank you so much for inviting me. Thank you, Sneha. Thank you so much.
Thank you, sir. Thank you so much. Shobhana, now I hand over to you once again for the further proceedings.
Thank you, ma'am. Now we'll move on to the first session, ma'am.
We have to invite
Chief Guest, Madam Umayal, Madam.
Yes.
Madam Umayal, ma'am. Madam, can
Yes, Shobhana.
Kindly invite the guest of honor, ma'am.
Sir, Dr. Parag Biniwale is a senior consultant of OB-GYN in Pune. He is a postgraduate teacher and the unit head of Kamala Nehru Hospital, and was the president, is currently the president of Pune OB-GYN Society.
Thank you, Dr.
Also
Umayal. That's enough. Thank you very much. Thank you for those kind words.
Sir,
Good evening.
Thank you so much.
Yeah. Gonna stop share.
Yeah.
Yes, sir. We would like to give you a few words about this conference.
Sure. Thank you for those kind words. Good evening, all. I bring greetings from ICOG, and it's indeed a pleasure to be joining this webinar as guest of honor. So let me thank the AMOGS office bearers, Dr. Rajendra Singh Pardesi, the president, Dr. Sujata Darvi, secretary, and Dr. Sneha Bhoyar, who is the chairperson of the Medical Disorders in Pregnancy Committee of AMOGS. It's indeed heartening to see AMOGS crossing boundaries and reaching to the societies of Tamil Nadu with a very important subject under discussion, and that is postpartum hemorrhage. We know that Maharashtra is a little better off as far as maternal mortality is concerned, but still there are a lot of mothers dying, and we as healthcare providers for women have to put our best foot ahead to prevent whatever we can. PPH is still something which is haunting all of us because managing PPH is a nightmare. And Sneha, I must compliment you that you have excellent speakers and panelists who will be deliberating on the subject of PPH. Our own PPH lady, Dr. Sheila Mane, who's the Vice Chairperson-elect of ICOG, is there, and a very experienced Dr. Shashilata Kabra, who will be talking about the management aspects. And of course, the panel discussion will be, we will be receiving good take-home messages, and we will always remember them when we are managing PPHs. So thank you very much for your invitation, and it's always a pleasure to be part of AMOGS activities. Thank you.
Yes, thank you so much, Parag. And now I take this privilege to invite AMOGS Secretary, Madam Sujata Dalvi, who is, very helping and generous and kind. That's all. I know Madam doesn't like to be introduced as, formal with the formal CV. So over to you, Madam. Please unmute yourself and please bless us.
Yeah, okay, fine. So as an Secretary of AMOGS, I welcome one and all for today's webinar, which is by AMOGS Medical Disorder Committee along with Tamil Nadu Society. And I would like to express my gratitude to AMOGS President, Dr. Rajendra Singh Pardesi, who is always an encouraging force so far as any of the academic activities of AMOGS are concerned. Would also like to express my gratitude to AMOGS Medical Disorder Committee, Dr. Sneha Bhuya, who is very active so far as conducting all these webinars are concerned. Like the words of wisdom, which was given by guest of honor, Dr. Parag Binewale, Vice Chair of an ICOG, and also like to have a presence of ICOG Secretary, Dr. Ashok Kumar. The topic is very apt, that is postpartum hemorrhage, and we have an expert speakers who are covering up the medical management and also the surgical management. And there are some panel discussion which is on near miss cases, going to be conducted by Dr. Sneha and Dr. Chamila. And I would like to wish our coordinator, Dr. Umayal Murugesan, and of course, Dr. Sneha Bhuya for their future endeavor in Foxy, and wishing you best wishes for today's webinar. Thank you so much.
Thank you so much, Madam, for your blessings and the wholehearted support always. Thank you so much. And I take this opportunity to welcome Dr. Ashok Kumar and hear a few words of guidance from him. So all of you know that he is the Secretary of ICOG at present, and academically very sound person, I would say, very humble human being. Over to you, sir.
Thank you. Good evening, everyone. And I take this opportunity to thank Dr. Sneha Bhuya, who has invited me for this webinar. And this is the opportunity to meet all the stalwarts for AMOGS and Tamil Nadu societies. Dr. Pardesi, President AMOGS, Secretary Dr. Sujata Madam, and office bearers of Tamil Nadu societies, along with obviously my dear friend Dr. Parag, Vice Chair ICOG, and Dr. Sheila Mane, Vice Chair elect, the coordinator and convener of this program, Dr. Umayal and Dr. Anit and Sobna ji. So thank you very much. Indeed, it is a very good academic program where all spectrum of mortality and morbidity, PPH, along with near miss will be discussed and by the eminent speakers and the panelists. And ICOG, the academic wing of Proxy, and ICOG always encourages all the academic activities and CME which will benefit all the Proxy and obviously this PPH and near miss are the main concern in our society, in our day-to-day practice, where it is needed. ICOG has also lot many courses as well as physical courses, as well as the online courses, where these type of hands-on training and the teaching activities are being conducted. So we hope that all the members and all the participants of this webinar will take benefit from all the activities of the ICOG. All these activities are available on the ICOG website. So I request everyone to visit ICOG website and take note of all the activities being done by the ICOG. And with this year, Dr. Lakshmi Srikhande, chairman of ICOG, has done lot of and planned lot of academic activities in a month, and those are the cycle which are being run every month. So I request you to take benefit from all those activities. With these words, I would like to also give my wishes to the best wishes to Dr. Sneha Buhar and Umayal for their future endeavor in Foxy, and we hope that your wishes are successful and fulfilled. Thank you very much.
Thank you, Dr. Ashok Kumar. Dr. Umayal, do you want to say something? I think she's traveling, and that's the reason I have taken up the lead here. So I just thank all of you once again, respected President of AMOGS, Dr. Pardesi, Sir, Madam Sujata Dalvi, the Secretary, and the whole of ICOG team. I would say today, Dr. Lakshmi could not join because she is in UK, and the Secretary, Dr. Ashok Kumar, the Vice Chair, Dr. Parag Biniwale, and Madam Sheila Vane, Vice Chair elect. So we have the whole team of ICOG here, and of course all the faculties, Madam Sheila Mane, Dr. Shashi Kabra, all the president and secretaries of Maharashtra as well as Tamil Nadu societies, and all the panelists, and even the moderator, our dear friend Dr. Charmila, who will be joining shortly. So I thank one and all, and with this I declare that the inauguration is done, and I hand over to the coordinators, Dr. Shobhana and Anit Kumar. I thank both of you, and also I thank the convener, Dr. Umayal Murugesan. Over to you, Dr. Shobhana. Thank you.
We will now go for the academic session. I now request our co-coordinator, Dr. Anit Kumar, to introduce the chairpersons of the first talk.
Good evening to everyone. So I have the honor of introducing the chairperson for the first talk, medical management, PPH and hemorrhagic shock. The chairperson are Dr. Chanchal Ghaziani ma'am and Dr. Umayal Murugesan ma'am. Dr. Chanchal madam is a POX president of 2324. She's the director of RK Hospital and practicing in Pusar for the past 20 years. She's involved in many social activities like orphanage and old age homes, and she loves working with blind people also. Next, I'd like to introduce Dr. Umayal Murugesan madam. Umayal Murugesan ma'am, she is currently the secretary of Kanjipuram OG Society, Tamil Nadu, and the president of IMA Tambram. She is actively involved in various Foxy activities, and she has special interest in high-risk obstetrics, infertility, and laparoscopy. I kindly request the chairpersons to introduce the speaker, Dr. Sheila Mane ma'am. Dr. Chanchal ma'am, can you please introduce the speaker?
Thank you so much for giving me opportunity to introduce Dr. Sheila Mane ma'am. And I really feel that she doesn't need any introduction. Still, I'm introducing her, and it's my really privilege. She's the ICOG Vice Chairperson, like 2023. She was Vice President Foxy 2014. She's Chairperson Safe Motherhood Committee 2013, President BSOG 2005-2006, President BMS Bangalore 2019 to 2021, National Facilitator Adolescent Health Committee WHO. Just one sec. Yes. Hold on. Yeah, and she's ICOG Governing Council Member 2020-22, ex-President Bangalore Menopause Society, President ISOPUB Bangalore Chapter, Reviewer for Jogi, and Faculty PIGO PPA Stimulator Workshop. It's really privilege to welcome her, and welcome Sheila Mane ma'am. We are really eager to hear you. Thank you so much.
Madam, we cannot hear you.
Sheila Mane, madam, welcome to the CME, and we are looking forward to hear you talk on the medical management of PPH. You are known as the PPH lady in Foxy because of your wonderful work on the PPH as a coordinator. And we are really looking forward, madam, about what you are going to tell us about the medical management. Welcome, ma'am, and waiting to hear you.
Madam, we can't hear you, Madam Sheila, madam. Please check your audio of the device. Please increase it.
We couldn't.
I'm not able to hear you, madam Sheila, madam.
We couldn't.
Your
couldn't
device
hear you,
volume,
ma'am.
madam. Please adjust your device volume.
Madam, on the top line, I think there is F7 button which you have to press for sound.
Also screen sharing, madam. You have to share the screen for the PPT.
Bhavna, can you help madam?
Yes, ma'am. Can ma'am join once again? Leave the
I
meeting
think
and
that
join
will be
once
better.
again.
Yes,
And when the device will ask to join
join.
the audio with computer
I think that will
device,
be
you have to click OK.
Right.
Madam, log out and log in once again. Yeah. So, Shashi, have you tried screen share? Or have you tried whether the videos are running well? If you can just try once.
Yeah,
by the
yeah,
time you
okay. I'm
join.
sharing my screen.
Yeah. Yes, we can see only try playing the videos once again.
I'm just trying one video. Is it coming?
This is the anterior sides of radius.
Yes.
Showing the LSC.
Yeah?
Yes, ma'am.
Yeah, yeah. So
Yes, perfect.
Uterus is exteriorized, and I will pierce the needle through the point A and will.
so it is fine, ma'am? Dr.
Yes.
Sneha? Yeah, okay.
Yes,
So I'm
yes,
stopping.
yes, absolutely fine. You can
Can
stop.
you hear me now?
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am. We were able to hear you now, ma'am.
Okay, good, good,
Yeah.
good.
Please share your screen.
My screen is visible?
Yes, ma'am. But
Make it full screen slideshow mode.
Yeah, that I'll do. Yeah, fine. Thank you. Thank you, Dr. Sneha, AMOGS, Dr. Pardesi, Dr. Sujata for giving me this opportunity, as well as the Dr. Umayal, Dr. Shobna, and the Tamil Nadu societies. Okay. So first I will talk about medical management, and then I'll talk about the hemorrhagic shock. Now, medical management, I think all of us are really geared up. So, but you know, there are still we know that there are drawbacks, and still we are losing mothers. So now when we say postpartum hemorrhage, we cannot say that we can have zero PPH. That is not possible. But let us look forward to see that we have zero deaths due to postpartum hemorrhage. So that is very important. Now, the treatment of patients with PPH has two major components: resuscitation and management of obstetric hemorrhage and possibly hypovolemic shock. Then identification and management of underlying cause of the hemorrhage. So we may have to have different components to discuss this separately, but we have to remember that successful management of PPH requires that both components be simultaneously and systematically addressed. That means we are acting at a time when we say it is a golden hour. Now we have to look at the risk factor and the events leading to the diagnosis of PPH, which will suggest an underlying etiology. Most cases are caused by atony, and the need to be systematic argues for a planned stepwise approach to assessment and management. Now, status of the patient, severity of the bleeding, response to initial management steps determine if and when the protocol for massive obstetric hemorrhage is instituted. Now, all of us, we know oxytocin should be the drug of choice for both prophylaxis and treatment. We have to assess the tone by massaging the uterus, which serves to express any clots that are there in the uterus or vagina. Then boggy and not well contracted, you have to commence vigorous massage and therapeutic oxytocin. That can be 20 units in 1 liter of normal saline intravenously run as fast as possible. Or again, we can repeat 10, or we can also give 10 units intramyometrially with a spinal needle if no immediate intravenous access is available. Emptying the bladder may aid. If still remains atonic, we have to commence bimanual massage. Okay. Now, the compression expels clots and decreases bleeding. Massaging the uterus between the hands aids in promoting and sustaining contraction. Bimanual massage results in decreased bleeding because bleeding from uterus. And intramuscular carboprost is the second line agent and the dose is 250 microgram intramuscularly or intramyometrally. Asthma is a related contraindication, and carboprost has been shown to be 80 to 90% effective in cases refractory to oxytocin and ergometry. Now, misoprostol is again a valuable agent in the treatment of PPH, and recent trials are examining whether the more rapid onset of sublingual or buccal misoprostol will improve its efficacy in the setting of acute PPH. Now, but still remains a third-line agent in the management of PPH, the low cost of the drugs, so that it is used in the developing world. And I won't say investigational, now very much carbetocin is with us. That is heat stable carbetocin and champion trial, which happened in India. I mean, the KLE Institute from Belgaum conducted it in 10 countries, and now the carbetocin 2018 WHO guideline. WHO has included carbetocin in the active management of third stage of labor, but carbetocin is only used for active management of third stage of labor. The another drug which is added to our armamentarium is the tranexamic acid. Now, whenever the bleeding proves unresponsive to uterotonic, consideration may be given to tranexamic acid, which is a synthetic derivative of lysine with antifibrinolytic properties. Now, recombinant activated factor 7A, which is coming up now, it is very expensive, but it can be used whenever there is a massive blood loss. So, tranexamic acid, Cochrane review reported decreased blood loss after vaginal and cesarean birth. But again, you know, there are TRAP1 and TRAP2 trials going on where we can use it prophylactically, where we can use it in anemic patients. So, tranexamic is going to come in a big way in recent time. Now, we also have a WHO E-motive trial. Now, the E-motive trial mainly look at the blood loss assessment, and why the E-motive trial came into picture by the WHO is because the diagnosis and the starting of the resuscitation was getting delayed. So what is the E-motive? M is for massage, O is for oxytocin, T is for tranexamic acid, IV fluids, because we have to give isotonic fluids 1:3. And then again, you have to elaborate and see whether there is any trauma, whether the patient is still not responding, and then you go for refractory PPH management. So women trial, all of us are aware, and WHO has provided, Japaigo says it has to be given within 3 hours for its maximum action. So if the bleeding persists, even administration of uterotonics, then bimanual compression of the uterus, external or internal aortic compression, we can use balloon tamponade. We have to use, better to use anti-shock garment for the treatment of shock or whenever the transfer is required to another care or while waiting for a cesarean, because Even though it acts as a first aid, we can buy some time because it can prevent further blood loss. And if the patient has not responded, yes, we go for surgery. Now, internal bimanual compression to stop excessive blood loss. So we'll have to explain to the woman and family the need to do. At least the woman we have to tell, we should use clean hands, sterile gloves, place one hand in the vagina, clench hand in a fist, then place another hand on the fundus. All of us are aware. And then bring the two hands together to squeeze the uterus between them, applying pressure to stop the bleeding. And keep the uterus compressed until able to get medical support. We may get one more butterfly shape instrument shortly, which will again help us. Instead of using the right hand in the vagina, in the anterior fornix, we can just apply that. So we can use only left hand to compress the uterus. Now, aortic compression is coming up in a big way, and it is very important. It does not prevent or delay of aortic compression does not prevent or delay any of the other steps. That means you have to go on whatever other remedies are there, but the circulating volume is restricted to the upper part of the body. Blood pressure is kept higher. Blood is prevented bleeding from the bleeding area in the pelvis. And a qualified person at hand may have to carry out the compression to stop massive bleeding. If we are doing a cesarean section, we can do it internally. You can take a small mop, which is wet, and directly compress the aorta against the spine. We can do it directly. As soon as possible, this technique is assigned to a helper so that the most qualified person is not tied up and the interventions are not delayed. And blood is conserved by cutting off the blood supply to the pelvis via compression. For aortic compression, you have to explain it to the woman. If she is conscious, reassure her, stand on the right side, place the left fist just above and off to the left of the woman's umbilicus. That is, the abdominal aorta passes slightly to the left of the midline. If you are on the right, you will be compressing inferior vena cava. That's why you have to go above the umbilicus and left side. Lean over the woman so that your weight increases the pressure on the aorta. You should be able to feel the aorta against your knuckles. Do not use your arm muscles. This is very tiring. Now, before exerting aortic compression, feel the femoral artery for a pulse using the index and the third finger of the right hand. Once the aorta and the femoral pulse have been identified, slowly lean over the woman and increase the pressure over the aorta to seal it off. To confirm proper sealing, check the femoral pulse. And there must be no palpable pulse in the femoral artery if the compression is effective. Should the pulse become palpable, adjust the left wrist and pressure until the pulse is gone again. The fingers should be kept on the femoral artery as long as the aorta is compressed or in between to make sure that the compression is efficient at all times. And recently, when I attended a WHO global meet, there was a paper from Norway where they say, we know that the blood is not easily available. The patient is thin, it can be done easily. So we have to see it that we are doing all other measures, but we can do aortic compression. So ensuring that obstetric care providers are adequately prepared for handling hemorrhagic emergency should be accomplished through high quality medical nursing and midwifery education with ample opportunities to practice managing rare events and be verifying that all tools and material required for PPH interventions are readily available. So readiness is the key in case of an postpartum hemorrhage. Sorry, it is also important that standardized protocols and guidelines be adopted and monitored to ensure that facility level practices are evidence-based. And we have so many examples like this where people have already done and they have found out that if we practice all these skills and drills, definitely it will improve. So we had Mama Natale, we worked with Dr. Hema, and I introduced during my Safe Motherhood chairperson post, the emergency box, the emergency kit, which is also very helpful. So readiness is the key. So what is postpartum hemorrhage? Predict, prepare, and handle. Atonic is the commonest. Uterine blood flow at term is 700 to 800 ml, and the uterus can simply pour. Now, even smaller blood loss matters in women with low BMI, anemia, and preeclampsia. Now, why in low BMI? Suppose if you take a patient's weight in kgs, suppose she is 35 kg, multiply it by 100. So her blood volume will come to only 3,500. And imagine if this woman has lost 1000 ml, she will definitely go into a shock. So another is anemia. Now, anemia is the cause for PPH, in fact. Not only that, we have to be careful. Why? The anemic patient's heart rate is more, so the stroke volume is more, she bleeds more. Okay. Then the fibrinolytic activity where the is faster, that means the clots are dissolving early. Then In the blood vessel, there is no lamellar flow. During normal flow, the platelets are at the periphery of the vessels, which is disturbed because the viscosity is increased. As the blood is thinner, the RBCs are less. So this is the fourth cause. And the fifth is iron deficiency anemia. During pregnancy, also keeps the myometrium weaker, even it cannot contract and retract. So we have to see to it that the patient is not anemic. If she is anemic due to these 5 causes, she is going to bleed. We know all this AMTSL. So the golden hour is the medical management. I always say that we should have a code H and we should shout for help, resuscitate, IV fluids, oxygen, arrest the bleeding, uterine massage, more uterotonic, and communicate with the staff, with patient and family also, and identify the cause of bleeding. ABC, all of us we know, immediately start oxygen, start infusion, either normal saline or ringer lactate 3 times in volume to the blood clot, but you should arrange the blood because otherwise the patient will go for dilutional coagulopathy. You have to have a gray color cannula in your PPH box so that you can transfuse 180 ml per minute. It makes a difference. Your patient is bleeding. Okay. Medication, oxytocin, first choice. Then comes carboprost. You can repeat it every 15 minutes till 2 milligram. Methyl ergometrin also can be given. It does help for lower segment bleeding, and misoprostol 800 microgram rectally as a therapeutic. So you have to identify the cause of bleeding, evaluate for atony, lacerations. There could be hematoma, inversion, retained tissue, acrita, or coagulopathy. Parameters to be assessed, vital parameters. All of us, we know that. Look at the shock index, very easy. Pulse rate divided by systolic blood pressure. If more than 1, it indicates that the patient is in shock. And rule of 30, because fall of blood pressure by 30 millimeters of mercury, increase in the heart rate by 30, output less than 30 ml per hour, hematocrit less than 30%. The amount of blood loss is 30% of the whole blood volume, and that comes class 3 hemorrhage. So you have to act faster, get the blood and blood products. So all of us are aware of this. These are the oxytocics which need to be used, and we know the side effects are minimal and there are no contraindications for oxytocin. And in 24 hours, we can go up to 100 units. So with patient, even she can even help by doing uterine massage, inform the family, the staff, the seniors, because anytime your patient goes into massive hemorrhage, you will need a help, a lab person, a blood bank, everybody. So your support system also should be informed, alert the blood bank, look at the shock index, infuse IV fluid immediately, hypotension, you will have to activate massive transfusion protocol. And if not, all this is happening within the golden hour. Even the refractory PPH also should be managed so that the patient does not go into shock. Now, carbetocin, I think all of us have heard since it has come, and we know if it is given, there will be a rhythmic uterine contraction which will last for 120 minutes. We are using it, heat stable we have, and we really find that hardly there is blood loss, any blood loss if it is used intravenously. I told already about the WHO recommendation, so it is there. And these type of charts should be there in our labor room. So even if we are not there, the people, they should check the vitals, they should start the directed therapy, and they should know how much oxytocin to use. So this is the chart which we had prepared when I was a Safe Motherhood Committee chairperson, and we should see to it that regularly we are training the nurses and the midwives. So thank you. I think I will stop this and then go back for my another presentation, that is treatment of hemorrhagic shock. Is that okay? Can I share that now, Sneha?
Yes, madam. Sure. Go ahead.
Because when we are talking about medical management, we also know that the patient is bleeding. So it's very important to see to it that she should not go into hypotension or she should not bleed. So hemorrhagic shock or hemorrhage need to be managed. So the team leader is very important whenever there is a diagnosis of PPH, because takes the important decisions and assigns responsibility to other members so that there is no chaos, who promptly follows the discussion. And this team approach helps in proper diagnosis, investigation, and treatment, as well as for monitoring. So a quick assessment, because shock is defined as the syndrome initiated by acute hypoperfusion, leading to tissue hypoxia and vital organ dysfunction. And one should not reach this stage. We want to avoid this triad. So it is a systematic disorder affecting multiple organ systems. Now, shock in a pregnant woman differs because there are normal physiological changes and mother and fetus are both vulnerable. Hence, simultaneous assessment and management of the mother and fetus, that is during antenatal period. So it is characterized by decreased circulatory volume. Okay. So mother is first. So you have to do ABC, that is airway, breathing, circulation. Now, when to suspect? When there is air hunger, the patient says, I can't see, diminution of vision, she is restless or decreased consciousness, low blood pressure, rapid, weak pulse. I would like to tell you here, now, since the monitors have come, people have left looking for this. All the seniors will agree here that we used to always look at the volume of the pulse, and we knew at that time only that there is a hypovolemia. Yes, pallor, of course, cold, clammy, sweaty extremities, and decreased urinary output. So this is the classification of hemorrhagic shock. We should have this chart in labor room. Why? Because till the patient goes into class 3, she will be still stable. There will be just tachycardia in class 2, even though she has lost 15 to 30%. And you may find she is conscious. There may be, but the blood pressure will be still normal, but maybe that the diastolic also will be lesser, which we have to look at the mean arterial pressure. Yes, we just give fluid replacement here, but we'll have to immediately arrange blood, because we don't want class 1 to become class 2, class 2 to become class 3. In class 3 and class 4, again, you have moderate and severe. The patient has already lost 1,500 to 2,000 ml. She will have hypotension, her respiratory rate will be more, profound tachycardia, shock index will be almost 1.2. Okay. And in class 4, the patient will be unconscious. There could be air hunger also. So we have to see to it that immediately the patient is resuscitated. So you have to call appropriate members, alert the blood transfusion services, hemorrhage control, airway control, breathing support, and circulatory support, fluid resuscitation, blood transfusion or massive transfusion, and in case of PPH, management of the cause and stepwise initial resuscitation steps. Investigations, complete hemogram, okay, white blood cells, platelets, peripheral smear, blood grouping and cross-matching, even liver function test, LDH, renal function test, coagulation profile, arterial blood gases if needed.
Madam, sorry to interrupt you, but your slides are not moving, madam.
Not moving?
No, they're not moving. Madam, please click on the slides and try to move because they're absolutely not moving, madam.
Now?
No, the first slide only.
Madam, you can come out of and then again try to screen share, madam. Sometimes.
Yeah, stop share and again.
This is happening today. Okay.
I think once again you can try sharing.
Share the whole screen.
Is it there now?
Yes,
now
madam.
Can you see?
Madam, please try clicking on the slides. Try to see whether they are moving. No, they're not moving as it. Can you see on your laptop, madam, that they're moving?
It was moving for me earlier.
Yeah. Make it full screen and try.
What happens?
Is it showing enable editing? Just
You can see the mouse moving.
yeah. Click on some other slide, madam, if you can. From the side, if you can click on the other slides. Yes. Click on it. The slide share only is not happening.
Yeah, I don't know why.
Madam, if you can click on enable editing and then see if it is happening.
Yeah. Mm.
Ma'am, in your side windows, if other presentations are open, you can close it once. You can close all the other presentations and slide share, and then you can slide share. You need to close all the other presentations which are open in your side windows.
How do I close that? But
Now you can try sharing, ma'am.
no, it's not moving. See, what happens is when I'm sharing here, no, as you said, I think there is one more, this one is open there. How do I close that? How do I close that?
Just open that, and at the corner you see that cross, no? Just close that. Open that presentation first. Yes, madam, now you click on the cross. Yes. Close it first. Yeah.
Okay.
Now try sharing.
Now see?
Just try moving them. Click on the slide. Yes, madam. Perfect now.
From where do I start now?
Wherever you have, madam, up to the slide, you were speaking about the matter.
Yeah, this is the one I was talking. Okay. So investigations, all of us we know, because there could be other problems also when the patient has massive hemorrhage, could be a HELP syndrome or other problems. And these are the commonly used vacuum trainers. Vacuum trainers, you know, it's very important to know for what we have to collect, you know, these type of, I mean, the information put up in labor room really helps, because in case of an emergency, so we are talking about golden hour, people will not know what to collect where, you know. So if we have this, then immediately we can collect, so that, you know, we don't have to run around, and all these vacuum trainers should be kept there. So I will not go into those details, but just for your information, okay, that it should be kept. And ideally, test should be done immediately after the blood is collected, within 2 hours for coagulation studies and platelet count, within 3 hours for ESR, and within 24 hours for RBC, WBC, packed cell volume, hemoglobin, and reticulocyte counts. Okay. Now, arterial blood gas is again a very good investigation. And if you have a HDU, you have the facility, because it will help us to detect whether the patient is going in for acidosis. Okay. So arterial blood gas is a test which measures the amount of oxygen and carbon dioxide in the blood, as well as the acidity of the blood. And these are the normal values and the normal range of the pH, the CO2, the SCO3, as well as PaO2, so that we know whether the patient is going in for acidosis. Now, the method again, the blood is usually withdrawn from the radial artery. Anyway, we don't do this. Most of the time, the patient is in the HDU. So there are people who can help us. So, but you know, it is good to know that it is collected from where? Radial artery. And we should know that what do you mean by respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis also. So how do we manage the circulatory failure? IV access, IV fluid administration, pressure support, because if the blood pressure is still not recordable, you will have to give a NORAD, restore circulatory volume first with NS or Ringer lactate, and use the blood products if needed when available. And intravenous access, I told you about 16 or larger also, but now we don't use 14 and 18. BP, is inaccurate is a late indicator of shock. Mental status, look at the pulse rate. The capillary refilling may be better indicators of early shock. And do not use IV dextrose as it is a poor resuscitation fluid. Restore intravascular volume with crystalloids or colloids. And colloids can be used if no response to normal saline. Overall outcome are similar with normal saline versus colloid, so we don't use colloid nowadays. Goal is to restore perfusion because the patient is bleeding. Radial pulse pressure, systolic blood pressure should be more than 90. IV fluid bolus may not be needed. Place IV line with fluid only at maintenance rate. Okay, if the BP is more than 90. If it is less than 90, then you have to immediately give 500 to 1000 normal saline or 250 to 500 colloid. Repeat as needed. Okay, and administer enough IV fluid or blood to restore the radial pulse and maintain the systolic blood pressure more than 90 millimeters of mercury. If there is uncontrolled hemorrhage, very important is do not pop the clot. That means do not go on giving IV fluids, because if the clot is forming, it will dissolve, and you have to avoid over resuscitation because it can lead to DIC. Okay, so there could be dilution of clotting factors, hypothermia and coagulopathy, and this triad should be avoided. Adequate fluid resuscitation signs: patient looks better, improved BP, widened pulse pressure, decreased pulse rate, decreased capillary refilling time, resolved diaphoresis, improved mental status, and improved urine out. Coming to blood transfusion. Order blood transfusion if blood loss is ongoing and thought to be in excess, or if the patient's clinical status reflects developing shock despite aggressive resuscitation. Okay, we have to ask for PRBCs. They are initially used. And in an extreme emergency, when your patient is in class 3 and class 4, and you know that the cross-match blood or the other group blood is not available, all the BZ obstetric unit should have a O negative blood. You don't have to cross-match. Ask them to immediately give, followed by, again, the respective blood group and RH type. Spin method for cross-matching can be used in an emergency. And if coagulation tests are abnormal from the onset of PPH, consider underlying cause like abruptio placenta, HELP, because there is hemolysis, elevated enzymes and low platelet, fatty liver of pregnancy, IUD, amniotic fluid embolism, septicemia, and pre-existing disorder. So take specific steps to treat the underlying cause and the hemostatic abnormality. It is essential that regular food blood counts and coagulation screens are performed during the bleeding episode. And FFP, cryoprecipitate, and platelet should not be given on clinical suspicion alone unless there is a delay in obtaining blood results. But once we know that the patient blood loss we assess, and we know she has lost so much, we can ask for all the products. Infusion of FFP should be considered before one blood volume is lost. Okay, we have already given 4 PRBCs. We should order blood and blood products. Now, when to give FFP? It is at a dose of 12 to 15 ml per kg, should be administered for every 6 units of red cells during major obstetric hemorrhage. Subsequent transfusion should be guided by the results of clotting test if they are available in a timely manner, aiming to maintain the PT and APTT ratios at less than 1.5 into normal. It is essential that regular FPC and coagulation screens, that is for even PT, APTT, and fibrinogen, are performed during the bleeding episode. Cryo, when to give? We know cryoprecipitate is rich in fibrinogen. And whenever we order, we have to at least order 5 to 10 units. Is a standard dose of 2 5-unit pools should be administered early in major obstetric hemorrhage. Subsequent cryoprecipitate should be guided by fibrinogen results, aiming to keep the levels as 1.5 gram per liter. Now, the FFP and cryoprecipitate should ideally be of the same group as the recipient. If unavailable, FFP of a different ABO group is acceptable, providing that it does not have a high titer of anti-A or anti-B activity. No anti-D prophylaxis is required if an RHD negative woman receives RHD positive FFP or cryoprecipitate. Now, when should platelet be transfused? Aim is to maintain the platelet count about 50,000 per cubic millimeter in the acutely bleeding patient. Platelet transfusion trigger is 75,000. Okay, and the platelet should ideally be group compatible. RHD negative women should also receive RHD negative platelets. Massive transfusion is a replacement of more than one blood volume in 24 hours. or 10 units in 24 hours, or when more than 50% of blood volume is lost in 4 hours. So then here comes the damage control. Okay. So damage control resuscitation and damage control surgery. All of us, we know the surgical management, that is the compression sutures and all that. But you know, when this situation arises, it is a damage control resuscitation. And these are the triggers. Hemoglobin less than 7 gram, you have to give RBCs. 1 pack will increase 1 gram. FFP, when the PT is more than 1.5, 10 to 15 ml per kg. Platelets less than 50,000, 1 pack will increase only by 4,000. So single donor is preferred. Cryoprecipitate when the fibrinogen is less than 200. So 1 pool of 5 units is equal to 10 milligram per kg. And fibrinogen concentrate, which is available now, can be given 60 ml per kg. So that will increase the fibrinogen by 100 mg per deciliter. And you have to also monitor all this when your patient is in HDR ICU, all these acid-base status, temperature, ionized calcium, hemoglobin, platelets, everything should be monitored, including the fibrinogen and coagulation profile. Now, recombinant factor 7A is warranted in active obstetrical hemorrhage that does not resolve by conventional treatment or to prevent hysterectomy, or when you have given massive transfusions, it can reduce the number of transfusions. It decreases maternal mortality due to obstetrical hemorrhage, and use of this increases the risk. There could be a risk of arterial thrombosis by 2-fold, and adequate thromboprophylaxis should be administered to these patients following the acute hemorrhagic event. The optimal dose is unclear. However, it is preferable to start with a low dose, 40 to 60 microgram per kg, to reduce the risk of thrombotic events. Fibrinogen concentrate is available now, and I have a personal experience of using it. Very useful in cases of abruptio placenta, because we know that abruption patients go in for a fibrinogenemia very soon. Okay. It should be given without finding the value. It should not be given. Okay. But you know, when your patient is bleeding, like in 2-3 cases of abruption, I have used it. Okay. Each vial contains 1000 milligram of fibrinogen. It has the potential to administer relatively high quantities of fibrinogen. In relatively low, it is 50 ml infusion. And its benefits are that it is readily available, as it can be kept in room temperature or refrigerators. Okay, tranexamic acid, I have already explained. So all of us, we know that once PPH is diagnosed, we should use it. Vasopressors, okay, to target the mean arterial pressure of 65 millimeters of mercury. Norepinephrine is the first choice. Vasopressin 0.03 units per minute can be added to norepinephrine with intent of either raising MAP or decreasing the NE dose. Dopamine is not preferred now, noradrenaline is preferred, and only in highly selected patients. So low dose should not be used for renal protection. And all patients requiring vasopressor should have an arterial catheter placed as soon as practical if resources are available. And NEOS, again, this should be, we have to teach our people. It will help in timely recognition of complications, which in turn will assist in the management implemented in obstetric units of hospital. In UK, they found they improved the outcomes to reduce the morbidity and mortality with sensitivity very high, that is 89 and 79%. And it can be paper-based or electronic gadget. It is also provides clarity on roles and responsibilities of staff because there is a color coding. So you have to, in this MEOS, monitor, identify trigger, alert, evaluate, diagnose, and respond. Okay. So this form should be used for recording of physiological observation and MEOS scores. All actions, communications in relation to a deteriorating obstetric patient must be documented in the maternal notes. So carry out observations, then the score, follow appropriate pathway, and there are 3 colors, green, amber, and red. And once the green becomes amber, the midwife or whosoever is taking care of the patient should always alert the seniors. And these are the types of colors which are shown depending on the parameters. And we have to see that if we find that the patient is moving towards red from green to yellow and yellow, that means we have to act fast. So thank you very much for your patient hearing, and sorry for the inconvenience caused. But I thought medical management, all of us are aware. But now when the patient is bleeding, how fast we have to act is very important. Now in FIGO guidelines, 2 more things are mentioned. That is damage control resuscitation and damage control surgery. These are the new things in this. So damage control resuscitation is what I was talking about, okay? Where you have to see that your patient, if she has gone into hemorrhagic shock, to resuscitate her. And damage control surgery is that we have done compression sutures, we have done stepwise devascularization. You may have to do internal iliac artery ligation or hysterectomy. Or if there is a oozing from everywhere, you may have to even pack the abdomen and close the abdomen and again attend the patient after 24 or 48 hours. I know the expert Dr. Shashi Kabra is going to talk about surgical management, but these are the two things which are added in FIGO guideline. Okay. Once again, thank you very much. And let us move towards, see to it that all of us wait to work together to see that we have 0 deaths due to postpartum hemorrhage. Thank you, Sneha. Thank you very much for this opportunity.
Thank you, madam. Yes, I think we can, Shobana, yes.
I request Umayal madam to give comments on madam's talk, Sheila Mani madam's excellent talk. Umayal ma'am. I request Sanchal madam to give her a view on madam's excellent talk, ma'am. Sanchal ma'am.
Yes, Dr. Chanchal.
Chanchal ma'am.
Yeah, so I think
yes, ma'am. Yes, ma'am. Yes, ma'am. Sorry. Yeah, she.
You can comment on the. You can give some comments, Dr. Chanchal.
Yes, ma'am. She was excellent. She had thoroughly gave the knowledge about the medical management of PPS, and it's really, really useful for all of us, and that we can use this at our level also. So thank you so much, Sheila ma'am. Thank you so much for your thorough knowledge.
Thank you so much. Excellent talk as always. Congratulations.
One more thing is, 12 pe 12, see that your patient has 12 gram hemoglobin. So what 5 causes, I told that anemia causes PPH. I think we will bring down the deaths due to postpartum hemorrhage in a big way if we tackle anemia. Thank you.
Thank you.
Thank
Dr.
you so
Shobana,
much,
we can
ma'am.
go ahead with the second talk now.
Yes, ma'am.
So good evening. So I'd like to, after the wonderful talk of Sheila Madam, ma'am, I'd like to invite the chairpersons for the next talk by Shashilata Kabra Madam. Chairperson for next talk is Dr. Supriya Chidavar, past, and Dr. Bhuvneshwari Madam. Can I have the CVs? Dr. Supriya Chidavar Madam is a highly experienced and accomplished obstetrician gynecologist with over 35 years of experience in Pusa. She is currently the medical director of Medicare hospitals and also mentor for CPS and DNB programs. Madam is actively involved as a community secretary of JEM School and ambassador for Swachh Abhiyan in Pusa for year 2023. Madam has an extensive experience and knowledge in obstetrics and gynecology, a panelist and colleagues. Next, I'd like to invite Dr. Bhuvneshwari Madam as the chairperson. Bhuvneshwari Madam is a senior consultant and the Dharani Clinics, Chennai. Madam is a wonderful member of a Kanjipuram Obstetrics Gynecology Society and ever supporting and most academic person involved in our society. Welcome, Madam, to be as a chairperson. I like to ask the chairperson to introduce a speaker for the talk today.
Supriya ma'am.
Hello, good evening, everybody. It's my privilege
evening,
to, good evening. It's my privilege to introduce Dr. Shashilata Kabra ma'am. She is a senior specialist of OBGY and NB teacher of, I think, DDU Hospital. She is the president at Delhi Gynae from Southwest. She is a chairperson of PCPNDT committee.
I think there is a technical problem.
So I think you can stop sharing,
I can start.
Yes, you can stop sharing, Bhavna. Let's Dr. Shashi share her screen. I can just say she's a very dear friend. She has worked with me as a breast committee member, but this is her very different identity, and she is, I would say, she's the best hand, skilled hand available around Delhi as far as the operative management of PPH is concerned. Over to you, Dr. Shashi.
Shashi,
Thank
can
you,
I
Dr.
just take 5 seconds? Okay.
Yes, ma'am.
Dr. Sneha, I wish her a good luck. Okay. In
Thank
your
you,
future
madam.
endeavors, and all of us are waiting to see you as a Vice President of Oxy very soon. Okay. All
Thank
the
you
best.
so much. Thank you, madam. Thank you so much. Thank you.
So thank you so much for the kind introduction, and thank you so much, dear friends Neha, for inviting me here. Thank you so much to AMOGS Society, Tamil Nadu Society, Dr. Rajendra Singh Pardesi, Dr. Sujata Dalvi, Dr. Ashok Kumar, Dr. Parag, and Dr. Humayun Murugesan. So the first thing which I want to say is that we usually say that PPH is a nightmare, but PPH is not a nightmare. We are here to convert this nightmare to an expertise. So how will we get this expertise? By learning the skills and drills of PPH. Am I audible?
Yes, ma'am.
Yes,
Yes, ma'am.
very well.
Yes, ma'am.
So this is what I want to say, that you remove the word nightmare or panic from your dictionary. It has no place in the dictionary of a trained obstetrician. So these are the beautiful words given by Sir Ian Donald. While managing postpartum hemorrhage, time elapsed should not be counted in a minute. One has not lost 1 minute, but 60 seconds. So time is precious. It is time, and it is time. 1 minute has 60 seconds in PPH. Every second counts. A patient may die in 30 minutes because, as Sheila ma'am has said, that the blood flow is 700 to 800 ml per minute. And sometimes it cannot be predicted also. So this used to be called the first surgical management earlier, but nowadays these uterine balloon therapy are called mechanical or non-surgical management. This is a condom balloon, first introduced in Bangladesh and very cheap. Then this is Chhattisgarh balloon, devised by Dr. Nalini Mishra, and this is Bakri balloon. It's very good and effective, and it has got a lot of strength also. So coming to the surgical management of postpartum hemorrhage, we have conservative methods and radical methods. The only one point with conservative method is that these can be done only when the patient is hemodynamically stable. And these are like uterine compressive sutures, uterine artery ligation, ovarian uterine artery ligation, and internal iliac artery ligation. And the radical methods are subtotal hysterectomy or total hysterectomy. And these are usually done when either there is a trauma in which the uterus can't be saved or the patient is hemodynamically unstable. So coming to uterine compression sutures, they are the conservative surgical management for atonic PPH. So we have to rule out traumatic PPH. And the shock index should be either less than or equal to 0.9. As I have already said that they are tried only in hemodynamically stable patient. So when come to this, then over the years, Dr. B. Lynch started using chromic catgut. Initially, he started chromic catgut number 2, and later on he shifted to Vicryl polyglycine 910, and recently he has been using monocryl, which is polyglycapron 25 also. And everywhere you can see that the suture number is 1 to 2, and length is around 75 to 100 centimeter, because we have to take the whole suture, Bailey suture, in one go. Needle length is 70 mm, and it should be a round body needle, because if it is not round body needle, then it will, wherever it will pierce the muscle, it will cause bleeding. So showing my video on Bailey suture, just tell me that my sound is audible and the video is running. Is it fine, ma'am?
Yes, yes, perfect.
This is the anterior side of the uterus, showing the LSCS incision, upper flap, lower flap. This is the cervix, and this is the posterior side. Now, before applying Bailey sutures, we have to confirm whether the suture will work or not. So, we have to exteriorize the uterus, put one hand on the posterior side, one on anterior side. We have to compress like this, and we have to see if the bleeding is reduced. If bleeding is reduced after applying this pressure, then we can presume that this suture will work, and we can proceed with these sutures. To identify few points, on the anterior side, this is the LSCS scar. There is point A, 3 centimeter below the lower incision, and 3 to 4 centimeter medial to the lateral side. Then we have point B, 3 centimeter above the upper part of the incision, and 3 to 4 centimeter medial to the lateral side. And similarly, we have point E and F on the opposite side. And we move the uterus posteriorly. Then we have point C, which is just behind the location of point E and point A and B. And we have point D, which is just behind the location of point E and F. And they represent the site of insertion of the uterosacral ligament. Now proceeding with the sutures, this is point A, 3 centimeter below the lower flap. I am going from outside to inside at the lower flap and enter the uterine cavity. Then from inside to outside I am coming out through point B, which is 3 centimeter above the upper uterine flap. Now my assistant will help me and I will curl around the fundus. This distance is 4 centimeter middle to the uterine column. Hold it like this. This is point C. Now I will pierce from point C and will come out anteriorly in the uterine cavity. Now I am inside the uterine cavity. Again I will pierce through point D and will come outside. So this is the location of point D. And I have come out outside posteriorly. Assistant will again help and he will keep on compressing the uterus. Now I will enter the uterine cavity again through point E. And will come out again through point F. Assistant will throughout keep the uterus compressed and now we hold it. Then the uterine incision suture is to be closed and we have to take utmost care of the angles. And now I will tie the sutures. Keep it compressed. First turn, second turn. This is squaring of the knot.
2 turns in the first knot. This makes the knot stable.
This is second suture. And this is third suture. So it will look like this and you can cut it. So this is how the billing suture will look anteriorly and this is how the billing suture will look posteriorly.
So I have a picture of live billing suture also, but that video I will show you later on because time is an important factor. This I will show you later on. So coming to Heman suture.
Uterus is exteriorized.
It is done
when we pierce the needle through the point A and will come out through point C.
This is done when we open the abdomen after a vaginal delivery. Sorry.
Uterus is exteriorized and I will pierce the needle through the point A and will come out through point C. This is point C. And hold it like this. Assistant will keep compressing the uterus and 4 centimeter to the conlu. I will tie the sutures.
Again, the distance from the conlu is 4 centimeter and it is tied at the top of the fundus. 2 turns in the first knot.
Square the knot. Second knot. And third knot.
similarly, it is applied on the opposite side.
So this is Hammond suture in place. This is
Here there
anterior
is
side.
no LSCS scar, no LSCS
This
foot.
is posterior side.
So now I am showing you the Cho suture.
So now I will show you the Cho suture. This is also another type of compression suture only. I tell you one thing about the methodology of compression sutures. Actually, they are given through and through the muscle part of the uterus, and the purpose is to occlude the lumen of the spiral arteries, which is responsible for the postpartum hemorrhage. So, Cho suture are usually given in the fundus of the uterus, just below the fundus of the uterus, in the body of the uterus, and it is applied in the localized area of bleeding. We can apply multiple Cho sutures also. So now my assistant is holding the uterus. This is the anterior side of the uterus, and I'm showing you the Cho suture. For this, we have to take a straight needle because it has to pass through both the walls of the upper thick segment of the uterus.
This is a 10 centimeter round body.
This is catgut. So suppose I am applying a Cho suture here. So I will pierce through here and I will come out on the posterior wall. That's why the needle, long straight needle is required. Then I am piercing it posteriorly like this and coming out
It is a type of box suture.
Again, I will go to the posterior side and coming out anteriorly.
It can be a rectangle, a square, direction may be up and down, whatever.
And again, I will come out anteriorly by piercing from the posterior side. So just have a look. From anterior side, it is looking like this, and from the posterior side, it is looking like this. Now, assistant will hold the uterus, and I will just tie the suture.
Recently, I used this suture on vaginal vault after doing this.
One turn and
it is effective there also.
2 turn. Make the knot square. It is done like this. Assistant will keep compressing the uterus. Second knot and the third knot. Similarly,
this is the second suture also applied.
Second turn. Assistant will keep compressing the uterus.
Application of 2 such sutures.
So these are the 2 Cho suture applied. Anterior side, posterior side. So now,
so the uterine compression suture represents a significant advance in obstetric care, and every obstetrician should be well trained in placing at least one type of compression suture. RCOG says that a laminated diagram of building suture to be placed in every maternity OT. So now coming to step-wise devascularization, it's a beautiful picture showing all these vessels. Here you can see that this is LS scar, and these are the places for uterine artery ligation, upper and lower. And this is the place for ovarian artery ligation. See, the ovarian artery is here. We are not ligating this. The word ovarian artery ligation is a misnomer. We are actually ligating the anastomosis of the uterine branch of ovarian artery and ovarian branch of uterine artery. And here lies the anastomosis just medial to the ovarian ligament. So showing you the video of uterine artery ligation. Bladder pushed below. I am palpating the uterine artery. Suture material I use number 1 catgut or number 1 vicryl or even 10 vicryl. Take 2 cm of myometrium, 2 cm below the uterine incision. Take the needle from anterior to posterior side. Chunk of myometrium is very important to be taken. Now you just fan it out, and through the avascular area, take the needle out from posterior to anterior side. And in between the 2 bites of needle is the uterine artery lumen. tie the knot securely. There should be 2 turns in the first knot, and then each knot in reverse direction, which makes it a perfect surgical knot. Now, this is the distal ligation. Same method. First bite from anterior to posterior. Second from posterior to anterior through the avascular window in the broad ligament. You will be able to appreciate the avascular window, which I am showing here. So this is how it is. Right. As we repeat the procedure on the other side. So moving to the uterine ovarian ligation. This was shared by my colleague, Dr. Suma. Part of myometrium taken. You see, I'm taking the myometrium here, not here. It will bleed here too much. So this is the place we're taking the chunk of myometrium. This corresponds to the size of the medial border of ovarian ligament. Needle taken from anterior to posterior. Then through the avascular window. Posterior to anterior. And in between these 2 bites lies the anastomosis of the uterine and ovarian artery. So this is uterine ovarian ligation. We should repeat on the other side also. So now coming to the internal iliac artery ligation. So the indications are, it is a life-saving operation. Indications are atonic PPH, uterine laceration or rupture, abruptio placentae, placental adhesion disorder, all type of placenta accreta spectrum disorders, cervical pregnancy. Then in few gynecological cases, it is also used, but here I'm just concentrating on obstetrics. So we go back to our anatomy classes. This is abdominal aorta. At the level of L4 and L5, it divides into common iliac, which are 2 in number, and they make one inverted Y over here, this abdominal aorta. Then each common iliac artery successively at the level of the sacroiliac joint divides into an external iliac artery and an internal iliac artery. The external iliac artery diameter is bigger than the internal iliac artery, and they also make 2 inverted Ys. So what we are concerned with these 2 inverted Ys. We are not concerned with this inverted Y. So this is an inside picture of the same. This is lateral side, this is medial side, this is the common iliac artery, dividing into external iliac artery and internal iliac artery. Now, if you look at the picture carefully, then you see that this posterior division of the internal iliac artery is given immediately after it originates from the common iliac artery. So in a pool of blood, we cannot see this. So how will you measure this distance? This is around 3 to 4 centimeters below the origin of internal iliac artery from common iliac artery. So here we perform the ligation because this is the main visceral supply, including the uterine artery, and the posterior branch mainly supplies the parietal part. So the posterior division has got these 3 branches: ilolumbar, lateral sacral, superior gluteal. Anterior division's most important vascular supply are uterine artery, middle rectal artery, vaginal artery, superior vesical artery, and inferior vesical artery. And anteriorly, it is covered by the peritoneum. We call it retroperitoneum. It is basically the anterior peritoneum, the broad ligament. Medially, there is ureter. Ureter always lies in the medial flap, says that I'm a very goody girl. I lie on medial side and you perform internal on lateral side. Then inferomedial, we have internal iliac vein. Laterally, we have psoas major muscle, and infralateral, we have obturator nerve. So how does it work? Bilateral ligation results in 85% reduction in pulse pressure, 50% reduction of blood flow, and it converts an arterial flow into venous flow and facilitates coagulation and reduces bleeding, and life is saved. Initially, it is difficult in first three to five cases, and later on, one learns it quickly. The learning curve is not as long as in laparoscopic surgery. So these are my two companions when I perform internal iliac-artery ligation. This is called mixture forceps or right angle forceps. It is bent at 90 degree, and this is the thread. It is a silk thread which I made it just double. Most of the time I use number 1 silk, and if silk is not available, then I use Vicryl number 1 or 10, and I make the Vicryl double also. So you will see the uses of both. As I've said, I'm a teacher in Deen Dayal Upadhyay Hospital and teach postgraduate students. We have annual delivery rates of 10 to 12,000. And we have to do a lot of internal iliac-artery ligation. So when I was doing it, then I realized that my students do not understand the anatomy and they cannot assess properly. So I made a model for them. This is a part of glimpse of the model, which shows what is the anatomy of internal iliac-artery ligation.
This is common iliac artery. This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery, and we have to ligate the anterior division of the internal iliac artery. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go. Normally in the pool of blood, this posterior division is not seen. If I place my thumb here, then the length of my folded thumb is around 3 centimeters. So I'll just put my thumb here at the beginning of the bifurcation, and around 3 centimeters, this is the place where I can recognize the internal iliac artery needs to be ligated.
You recognize the place of ligation.
Right angle forceps, also called mixture forceps. It is bent at 90 degree and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. Internal iliac artery, this is internal iliac vein.
They are enclosed in a sheath.
Enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement. Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath. Never do like this because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. I have already made a place here for ligation, passing the right angle.
Make a place between the artery and the vein, and you have to graze your distal
gently I will
forceps.
open it, and I will get hold of
Grazing
the
the
vein,
artery.
and just
Because the artery
gently I
was-
will come out like this.
So this is the double thread which
This
I am
movement
using.
is very,
Gently I
very
pulled
gentle.
it.
Now next step is I will cut this and make 2 threads.
So with one thread we have made 2 threads. That means we have reduced the chances
And
of
this is
injury to
another
the iliac artery and
See,
vein.
this is plain and this is another thread. So look at the technique of applying ligature. I have taken hold of one ligature. I am not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand, and there will be massive bleeding. So I am giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is second turn, and I have tied it here. Then very gently I applied the second throw, and again very gently I applied the third throw. Without pulling the artery, I myself cut this. Just without giving any pull on the suture, I'll cut this. And just getting this.
This is the model, and the assistance was improved a lot after practicing on this. This is basically hands-on.
This is
training.
common.
So this was the case. She came to me 11 hours after delivery, and she had a very massive broad ligament hematoma extending from the fundus, top of the fundus, and this has involved the colpos and has extended and caused colporexis also. Uterine artery was retracted on one side, and I opened the abdomen by longitudinal incision because the shock index was very high, and I performed an obstetric hysterectomy in this case. Uterine artery was retracted on one side and the bleeding was not reduced. So I did bilateral internal iliac artery ligation in this case, and this patient received around 19 units of blood and blood products. So I'm showing you this case. This is an unedited live video which I'm sharing. This was my 100th number of internal iliac artery ligation. So you can see here, this is the round ligament pedicle, and by the side of the round ligament pedicle, I'm trying to open the peritoneum. We call it retroperitoneum. You see, I'm lifting the thin peritoneum, taking care of the underlying structures, and going laterally parallel to the infundibulopelvic ligament and trying to reach the lateral pelvic wall. I will open it around 5 to 7 centimeter, and every time you see that I'm taking care for not injuring the structures lying below. Now I've kept all the instruments. Only with my 2 fingers, I'm opening the loose areolar tissue. It does not bleed much because it is a loose areolar tissue. Now you can see here ureter in the medial flap, internal iliac, external iliac, and this is common iliac. I will make it more permanent. The upper side is right and the lower upper side is lateral and the lower side is medial. You see, I'm making it more permanent. This is ureter in the medial flap. This is common iliac, this is external iliac, and this is internal iliac. This one is internal iliac. This is common iliac. This is internal iliac, this is external iliac, and this is ureter in the medial flap. Now you see, I'm making it more prominent. Because the first important thing is recognize the inverted Y. So this is inverted Y. Now I'm pressing the external iliac artery and feeling the femoral pulse. It will go, and when I will release the pressure, it will come. Now I'm pressing the internal iliac artery. There will be no change in the femoral pulse. So doubly I confirm that this medial structure is the internal iliac artery. Now just see the same movement which I showed you in the model. I'm doing it here. I'm cutting the part of sheath with my mixture forceps. And I will make a window only at a place where I have to put the ligature. That is 4 centimeter from the origin of the internal iliac artery. This distance I've already measured, as you know, with my thumb. You can make your own parameter on your fingers. Now see, I'm making a window. The blue structure being seen behind is internal iliac vein. So beautifully it is dissected. This blue structure behind is internal iliac vein. I'm passing it from lateral to medial. Remember the word, on both the sides we have to pass mixture forceps from lateral to medial. The loop is ready beforehand, this double thread, and I will just take it out gently. If we pass mixture forceps from medial to lateral, then it will hit the external iliac vein of that side and will cause massive bleeding. So now the thread is passed below the internal iliac artery, in between the internal iliac artery and the internal iliac vein, because I've already made a space by a proper dissection. Now you see, I've cut the loop and made 2 threads. Now we'll see if the 2 threads are playing properly, and very gently I'm seeing which one is playing with which one. Once I've confirmed the continuity of the thread, now I'll apply the knot. And beautifully, you have seen the knot in the model. 2 turns in the first throw. Make the knot square, bend your head, bow your head, bend your back, and go on the superior surface of the artery and just place the knot on the superior surface of the artery. At no moment you will lift the artery. You have to take your finger to the artery. This is a very important message. Take your finger to the artery. So I've applied first ligature. You can see the ligature has been applied. Now the second ligature to be placed 0.5 to 1 centimeter away from the first ligature. This is called the anterior approach. There is one more called posterior approach, where we open the peritoneum 2 centimeter below and 2 centimeter lateral to the sacral promontory after pushing the uterus anteriorly. Now you see, I'm applying the second ligature. Again, 2 turns in the first throw. Placing the knot on the superior surface of the artery. Taking my fingers inside the abdominal cavity. This is the retroperitoneal. You can see the bulge between the 2 ligatures, which are 4.5 to 1 centimeter apart. Very gently, I'm cutting the thread. So now you can see this is external iliac artery, this is internal iliac artery with ligature, and this is the ureter, and here is the common iliac. So this is the technique of passing the right angle forceps from lateral to medial on both the sides, because if we go reverse, then we will hit the external iliac vein on that ipsilateral side. So these are my own tips. I have not copied it from any of the textbooks. In last 22 years, after performing so many internal iliac artery ligations, I made these important points. First thing is that open the retroperitoneum from round to infundibulor pelvic ligament or move towards the lateral pelvic wall. Then this is for anterior approach, and for posterior approach, you push the uterus anteriorly and behind, open the retroperitoneum 2 cm below and 2 cm lateral to sacral promontory on both the sides. Then as you have seen, I do only finger dissection. Then locate the bifurcation. This is very important. Inverted Y is the bifurcation. Then recognize internal iliac artery as medial structure. It does not cause any change in femoral pulse. I have shown you both in model and in video. Then movement of mixture forceps always from lateral to medial. Remember the word lateral to medial, and lateral to medial. Then careful not tying in the cavity. I have shown you 2 turns in the first row and go into the depth of the cavity, bowing your head and back. And 2 ligatures 0.5 to 1 centimeter apart. I've shown you in my live video. And the last line is also very, very, very important. Always do bilateral, because the chances of free laparotomy and morbidity and even mortality increases when we do unilateral. We had a lot of experience in our own hospital. So the FIGO in 2022 guideline recommends that internal iliac artery ligation is one of the options to rapidly control postpartum hemorrhage for the management of PPH when medical non-surgical approaches in compression sutures fail. And FIGO recommends that all obstetricians familiarize themselves with the internal iliac artery location. So the model will go a long way in identifying the location and with the technique of its ligation. So last but not the least is hysterectomy, which is a radical method. So it can be a partial hysterectomy. When it is usually atonic PPH, we do a partial hysterectomy. And when there is colporaxis or when there is trauma on the uterus or placenta percreta, then we usually perform total hysterectomy. The important points are that dissection is very easy because it is a postpartum uterus, but the pedicles are friable. So always apply double ligation on the pedicles. That's the important tip. And this is a case of atonic PPH, and you can see here, very well appreciate, this is a subtotal hysterectomy I performed in this case. There was 1.5 to 2 liters of blood, and this much amount of blood the patient received. We discharged her in a stable condition. I have a full video, but there is no time of this. And the very important, this is my own tips which I want to share with you. You see that this is a simple interrupted suture, and this is the figure of 8. I always apply this because it will be more hemostatic, and at the same time it will not cut through in a postpartum uterus and it will not slip. So this is my suture of choice. I have done almost 212 obstetric hysterectomy. So this is a base suture which is to be applied. And in fact, in gynecological hysterectomy also I applied this suture. I never use this suture and never use this suture. And this one important 1-minute video I wanted to share. This was a case of pre-diagnosed placenta percreta. Just you see that when you anticipate any problem, always make a longitudinal incision irrespective of the previous incision, and just see where I make an incision. It's a very beautiful video.
This is a previous scar. This is a transverse scar, but we will open this abdomen by longitudinal scar.
Here, this is a transverse scar. I'm opening the abdomen by longitudinal scar because I knew beforehand that I'm going to open a case of placenta percreta. You can well appreciate the discolored placenta percreta here. This is the placenta percreta. It has involved the bladder also. So just see what I do. This patient went home in a very good condition. So I have to enlarge my incision because I cannot make an incision on the placenta percreta. So in upper segment, I will give the incision about 2 to 3 finger above the upper limit of the placenta percreta. I prefer giving a transverse incision. Many people give longitudinal incision also. Only because longitudinal incision goes little above. So in the thick segment, I prefer doing this. So you see that I'm much beyond the level of placenta percreta and delivered the baby. And with placenta in situ, I performed hysterectomy in this case. There is no, we should not do any attempt of removing the placenta. So this was the after effect. I did a complete obstetric hysterectomy. I've already shown you a case of subtotal hysterectomy. This is total hysterectomy with placenta percreta, you see, my own case. So now we have done hysterectomy, we have done internal iliac artery ligation, still the patient is bleeding. So I face 3 such cases. One of them had severe coagulopathy, and one of them had jaundice, and the third one I don't remember. So these are the methods. You can put multiple Sergi cells or gel foam or multiple mops, tying them. And in 2 cases, I just packed the abdomen with a full drape sheet, and later on, after when the patient became stable after 48 hours, we reopened the abdomen and removed those drape sheets, and all the patients went home. So with this, if you allow me 3 minutes, then I can show you my live video, please, Dr. Sneha.
Yeah, you can run it.
Yes, yes. So
yeah, little fast forward.
Yeah, I'm doing it. So is it visible? Is it visible?
Yes, ma'am.
Yeah.
Yes, ma'am.
You can appreciate that this is an atonic uterus, and same 3 centimeters below in the lower flap, I've taken a bite, and this is a flabby uterus too. Then again, 3 centimeters above the upper flap, on the upper flap, I've taken a bite. Then taking a bite at point C, as I mentioned, and coming from posterior to anterior side. Then I'm in the cavity, going again from anterior to posterior side and taking my needle out at point D. And I'm placing the threads 4 centimeter medial to the conum on both the sides. You can see this. The thread length is around 90 centimeter because you have to do it in one go. Now I've come anteriorly, and again I've pierced the needle at the level of point E and coming in the cavity again. And now I will pierce it at the level of F and coming out again. And what is next? It is to be hold, and then we have to suture the uterine incision.
That's right.
Assistants will keep the uterus compressed. So now I'm taking care of the uterine incision. You can see that I'm taking care of the angle. Bleeding is reduced, and now after placing the threads properly, keeping the uterus compressed, I'm about to give the final sutures of Billinge. You can well appreciate that I'm giving 2 turns in the first knot. It is a very stable knot. Just use it from tomorrow. You will really love it. Now you can see that the uterus is contracted a little bit, and it is no more looking flabby, and the Billinge suture has become successful in controlling this bleeding. But this is done only, this is the posterior side and this is anterior side. But this is done only when the patient is hemodynamically stable. So with this, I thank all the organizers and thank you everyone for giving me this opportunity. And I believe that PPH is 100% preventable. We should make every effort to save a life, because when we save a life, a mother, we save a family. And I seek your valuable vote for ICOG Governing Council election 2023, going to start in September. Thank you so much.
Yes, you can stop sharing. That was wonderful presentation, Shashi, and that shows your experience and expertise in the field. Very nice. And we invite the comments from chairpersons.
Thank you.
Chairpersons, Madam, Dr. Bhuneshwari, Madam.
Thank you, Shashilata Maheshwari ma'am, for making the lecture visually appealing with videos, clearly explaining the surgical management option of PPH. Actually, it has been like we are seeing the lectures live, and it was so appealing that it goes directly to the visual center, and it's not like a lecture; it is like a workshop with hands-on as well. Thank you very much, ma'am. It
Thank you
shows
so
your
much.
authority.
Thank you so much.
It shows the authority you have over the subject, and we are really blessed to have you here today. There will be no questions or comments for your presentation, ma'am. It is so nice that it is explaining how you have done your profession with passion. So thank you very much, ma'am.
So, madam, this commenter made my day.
Madams, I've heard madams talk so many times. Each time I listen to her, there is something new to learn from her. It is wonderful hearing you talk again, madam. Thanks for the wonderful talk that you given.
Thank you.
Thank
I'm
you,
so pleased.
Thank you, madam. Now we will move on to the next wonderful panel discussion. And no more PPH is a nightmare for all of us by Shashi ma'am. Thank you so much, madam.
Thank you.
And now we will go for the panel discussion on near miss case scenario. I like to welcome the moderators of this panel, Dr. Sneha Buer ma'am and Dr. Charmila Ayavu. Dr. Sneha Buer ma'am, she's a managing director for Sukarta Hospital, and she is a chairperson for AMOGS Medical Disorder Committee and chairperson Breast Committee FOXY 2019-2021 and governing council member ICOG and president YOGS and founder clinical secretary YOGS 2003. She has various awards to her credits. She has more publication, and we welcome you, ma'am. And Dr. Charmila ma'am, who is vice president elect 2024 FOXY and chairperson clinical research committee FOXY 2016, ICOG governing council member 2021 to 2023. Charmila, Bhavna, can you show Charmila madam's CV, please? She is a national coordinator for UNICEF FOXY PCA, MEDA FOXY PG program, ISAR Gurukul 2022. She is past secretary to Trichoji Society and president, Menstrual Hygiene Management Consortium, joint secretary, Justice India Association. I welcome you, ma'am, for moderating this session. I would like to introduce the panelist for today's panel, Dr. Mary Genova, ma'am, who is the president of past president of Virudunagar OBGY Society, and Dr. Meena Agarwal, who is the president of Pusad OBG Society, Dr. Suhasini Bopi, who is the secretary of Pusad OBGY Society and director of Varad Netralaya, Dr. Tamil Kode, ma'am, who is currently professor in Tirunelveli Medical College and received Best Doctor Award and committee member in Tirunelveli Medical College. Dr. Sri Revati Sadasiva, ma'am, who is the president of Erode OG Society. She has special interest in infertility, reproductive endocrinology, and embryology. And Dr. Tenmuri, ma'am, is an associate professor, Changalpeta Medical College, who is specialist in high-risk obstetrics. And over to you, ma'am.
Thank you so much, Shobana, for that kind introduction. And I'm seeing Dr. Revati, Dr. Tenmuli, Dr. Kodai, Dr. Suhasini, and Dr. Meena Agarwal. I think Dr. Mary Janava ma'am is not joined. Is madam there?
She was there. She was there.
Okay, okay.
madam.
I see her. I see. Okay, okay. Yeah, welcome. Thank you so much. I'll just share my screen and start. After that, like two wonderful talks on PPH, I'm not going into PPH at all. I told Sneha that we are sick of talking about moderating panels on PPH now, because everybody is like, as Shobana said, we have seen almost like in live all these this thing, and Sashi is one of the best. I've heard her in so many conferences, and she's always, as Anit said, it's always new when you listen to her. And I would like to request that all your opinions matter, but please make it very short and sweet, because already we are running late and Sneha has to do her part of the panel. And that's why I request that you agree with me and disagree with the co-panelists, so that we just finish it off fast. This patient is a 32-year-old. She was a third gravida, like 3 girls born to her. She delivered at a local nursing home like 13 days back in her native place. And then the baby was sick, so it was transferred to the NICU in Trichy. And the mother was in the ward, actually. And this mother, she had fever for 5 days, and she was taking some medicines on OPD basis. She complained of like she had some oliguria and drowsiness for 2 days, but they thought because she was like away from a place and sitting in the ward and not eating properly, and it was not taken much importance of. And suddenly, one fine day, she fell unconscious, and that time she was febrile. The mother was responding only to deep pain. And when she was admitted in the hospital where I was there, her pulse rate was 130, BP was 140/90. She had pedal edema. Mother was jaundiced. There was diffuse purpuric rashes in both her lower limbs. Abdomen was quite soft. There was no tenderness. Uterus was well contracted and retracted, and she had no neurological deficit per se. We sent all the investigations because this was a dilemma, complete blood count, all the cultures possible, blood culture, urine culture, and cultures of clinically indicated size because she's under of delivery. So we took from the vagina also a deep vaginal swab. Arterial blood gas analysis was sent. Coagulation studies were sent. Urea, creatinine, electrolytes, and liver function test. The reports was urea 80 to 88, creatinine 2.7, bilirubin of 8, alkaline phosphatase 1143, both the transaminase is elevated, blood sugar of 116, platelet count of 69,000, albumin was 1.8, electrolytes sodium 130, potassium 5.3. All the hepatitis infections were ruled out. HIV was non-reactive. Malarial parasite showed a smear negative. Bleeding time of more than 15 minutes, clotting time of 6 minutes, prothrombin time of 41.5. Partial thromboplastin time was 51.6, but FDP was negative. So this patient had a problem of renal failure, hepatic derangement, thrombocytopenia, and coagulation derangement. Differential diagnosis. Revati, would you like to take that?
Yes, ma'am.
Yeah.
This patient probably I would consider HELP syndrome in her, and sepsis induced multi-organ dysfunction.
But why should a HELP syndrome go for sepsis?
Differential diagnosis. Could
Differential.
be either
So
HELP,
first is HELP and second is sepsis.
First is my thing is first HELP, and the next thing would be sepsis, which subsequently caused multi-organ dysfunction.
Okay.
And third thing.
What would have been the source of sepsis?
Postpartum endometritis would have.
Abdomen was quite soft. There's no tenderness per se, and ultrasound showed quite normal pictures. Actually.
Okay.
So okay, sepsis was a second. And anything else you would like to think about with those reports?
I also think about acute fatty liver of pregnancy.
Okay.
And her serum albumin, her renal parameters. She doesn't have a pre-existing renal dysfunction, but I think some renal pathology,
chronic renal problem,
chronic
which has
renal
got aggravated.
pathology also, which got aggravated.
Okay.
So these are my differential diagnoses.
Okay. Any of the panelists like to add something, or you agree with Revati totally?
Can I add Dr.
Yeah,
Tenmuli?
Meena, please. Meena?
Yeah, I agree
Madam,
with
Dr. Kainmuri, can I
Katilwara.
add, madam?
Who? I can't see.
Dr. Kainmuri, madam, can
Yes,
I add,
ma'am.
madam?
Yes, ma'am. Yes, ma'am. Yes, Dr. Tenmuli, please.
Dr. Kainmuri.
Yeah, please add. Dr.
Can I be
Tenmuli,
here,
please continue.
Yes, sir. Madam, dengue shock.
Dengue shock. Okay. You're thinking of dengue shock. This thing, Dr. Kodai, would you like to say something?
Shock syndrome. Can it be, madam? Because the AK is there, injury is there.
Okay, okay. So yours is dengue shock first. Dr. Tenmuli, dengue is your choice. Yeah. But we did all those titers, it was negative. Dr. Kodai, would you like to add something? Madam, Dr. Kodai, madam. Madam, you have to unmute yourself. Yeah. Ma'am, we can't hear you actually.
Can you hear me?
Yeah, yes. Now you're audible. Yes, ma'am.
Yes, ma'am. Good evening, ma'am.
Yeah,
you have ruled out dengue shock syndrome. So,
yes, we ruled out dengue actually.
Yes, ma'am. So puerperal post-natal infections. So I agree with the first speaker.
Okay, so Dr. Revati. So we'll just add dengue to the differential diagnosis of what Dr. Revati said.
Yeah.
So as you all the panelists said, we thought of HELP syndrome as a first diagnosis. Acute fatty liver was second. Puerperal sepsis was third. Postpartum endometritis. And we also thought about the imitator syndromes, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, and SLE, catastrophic antiphospholipid antibody syndrome, because of this dramatic picture of both liver derangement and the kidney problem happening so quickly. Suppose she is HELP syndrome. Dr. Tenmoli, where would you like to admit her?
She has to be admitted in a multimodal treatment.
Yes,
So,
multi-speciality, and you will not keep her in the small center. Yes, ma'am.
Yes,
yeah.
ma'am. Okay, we need a nephrologist, a hematologist, a physician, and an anesthetist.
So no, just take it as HELP syndromes. How will you manage it?
Yes, HELP syndrome. So that is liver enzymes is elevated. We have to give her an adequate IV fluids, take care of her fever, and we see her IVO chart. The strict IVO chart have to be maintained. And for platelet, we did not give platelet transfusion because it is more than 60,000. And we have to observe in the ICU. Wait for control her BP pulse and general take care of her general measures.
Her blood pressure was 140/90. Would you like to give her antihypertensives?
140/90 we can wait, madam. We are not giving.
You're not giving. Will you give magnesium sulfate?
Yes, madam. For HELP syndrome, we will definitely
give magnesium sulfate, but not antihypertensives, because you think 140/90 is quite okay.
140/90. If it goes above that, we will definitely.
Okay. So investigations we have done all, and would you like to repeat them? And when will you repeat them?
Peripheral smear.
Yeah, we did the peripheral smear also. That was not so conclusive.
So it is repeated every 48 hours, madam.
And the other investigation, the liver function test and the renal function test, how often would you like to repeat? In the coagulation profile, because you said you'll give component therapy. So how will you repeat the investigations?
Repeat investigations is done in 24 hourly, madam. But the LFT is repeated after 48 hours. Okay,
so all the investigations every 24 hours, and that will be for 48 hours. Even your coagulation profile? That also you'll repeat once in 24 hours? Or would you like to do little earlier?
Yes, ma'am. 12th hourly we can do.
12th. Okay. So we repeated every 6 to 12 hours, and because it was a severe disease with renal compromise and there was a suspicion of imitated disorder, coagulation tests were repeated, prothrombin time and APTT were repeated. And as you said, fluid balance is extremely important when you suspect HELP or AFLP, with particular attention because of the decreasing or absent urine output. Dr. Kodai, would you like to take this question on coagulation defects management?
Okay, ma'am.
How will you manage the coagulation defects that she had? How will you order for blood components? What will be your basis? Do you want the reports again?
Yeah.
Okay.
You can show me the reports.
Okay. So how will you order for blood? DIC she's in. Even though FTP is negative.
What is the hemoglobin now?
Hemoglobin was 10.9 at admission.
Yeah, so we need the components, ma'am. Usually we order for cryo and
no, cryo FFP will order, but how much? How do you want it? Because they are not going to give it whenever we ask.
we usually order for 4 units and 4 units of cryo and 4 units of
similar to a massive transfusion protocol.
Yes, ma'am.
Yeah. So you'll ask for 4 cryo and 4 FFP. Is there a basis for like how you order that? They based on your PT, APTT or fibrinogen level? Do you do anything in your center before you place an order for component therapy?
We usually do the prothrombin, APTT.
Yeah.
Based on that only.
So how much will you order based on that? Weight basis of the patient or fibrinogen level, anything you base your ordering on?
Prothrombin time, based on prothrombin time.
So how much I'm asking? Because we need a baseline of how you are going to place your order, no? Because the blood bank will not accept like whenever we ask, they're not going to give us.
Yes, ma'am. We are having a IHBT specialist with us.
Okay, so they will place the order.
They usually give the some products for us.
Okay.
They usually don't go for us, and they give the samples and based on their own.
Okay. Any other panelists would like to take that question of how we are ordering, because they have a very good blood bank which is going to provide them like whenever they're going to ask. Can I ask Meena? Meena, now Aurangabad, what are you doing? No, I'm sorry, Pusad. Sorry, Meena. Yeah.
Hi, madam.
How will you order if you have a patient like this, Meena? You got a facility. Okay.
If we want
I'm not able to hear. Dr. Suhasini, would you like to say something? Actually, Meena, we are not able to hear you actually. Dr. Suhasini, would you like to take that question?
Sorry, ma'am. I will send it to multi-speciality.
Yes, okay, fine. Perfect.
Madam, I would like to add something based
Revati.
on our local institutional protocol. Basically, we look into PTINR, APTT and serum fibrinogen. We calculate the dose like FFP whenever we order. It is like, basically we base it on serum fibrinogen. So that's how we order this cryoprecipitate. If it's less than 1.5 gram, we expect each unit to increase by 30%. So and FFP, it's like 12 to 15 ml per kg, and every unit we expect it to raise by 30%. Now, for a particular patient, it's around 41, and I think her INR is also quite high, 12.
Yeah, quite high.
And it's quite, now we have to bring it to like 1.5 times of normal. So it's around 12 to 16.
Okay.
So based on that, as madam said, maybe 4 to 5 units.
Yeah.
But usually whenever we give the order, especially foreseeing this massive transfusion protocols, not less than 5 and not less, both cryo and FFP, we don't order less than 5. So that, because in a
so similar to what Dr. Kode said, like, it could be like a massive transfusion protocol. 4 you do. Okay. But actually, you can base it on, as Revati said, fibrinogen levels is needed at around 100 to 150. When it's falling, you have to place your order. Remember that a 40 ml pack of cryoprecipitate will increase the fibrinogen by 10. And a 250 ml of FFP also will increase the fibrinogen only by 10. So suppose you have a fluid problem, do not give FFP, give cryo. When you may overload and she may go for pulmonary edema. So remember that FFPs are known to cause pulmonary edema, and your target should be you should cross fibrinogen of more than 250. So suppose she has 100, you have to give 15 packs of cryo actually to make it to 250, because it will increase only by 10. And the cryoprecipitate is always preferable when the fluid overload is a concern. And remember that when an INR of more than 1.5 is present, it indicates you got almost a 70% fall in the coagulation products. So at least a 10% replacement is needed to stop that ongoing bleeding. So this is what Revati also said. 10 to 15 ml per kilogram body weight is the best method to calculate for FFP. So suppose the patient is of 60 kg, you will have to ask for 3 to 6 bags of plasma, as both of them said, Dr. Kodaya and Dr. Revati. When suppose she's bleeding heavily, and she's got more of complications, you can actually go up to 30 to 35 ml per kilogram body weight, and that will translate to 8 to 14 bags of FFP or cryo. And a fibrinogen of more than 400 it is associated with a very low rate of progression to ongoing bleeding. So if you keep it at that safe level, you will be much more comfortable. And remember that if the platelet count is decreased, even if you give your component therapy, it may not improve the patient's clinical status because platelet function may be abnormal along with the fall, and that's going to cause more problems. Always remember that you need to replace platelets with single donor platelets when needed. Even though it may be disappearing from the circulation, at least for that acute phase, you'll also need platelets. Target should be this: hematocrit of more than 30% and INR of less than 1.5 and fibrinogen at 200 to 250 should help you to tide over the crisis. And what about platelets transfusion? Can I ask Dr. Sugasni, would you like to take that platelet transfusion? When will you order for platelet?
If the platelet count is less than 50,000, then
yes, ma'am,
platelet transfusion is ordered.
Ordered. And suppose you're going for surgical interventions, be very careful that your platelet level is at least crossing 50,000. Otherwise, you will have problems. But suppose you're not going for surgical interventions like this patient, she's delivered already. So platelets may not be needed, because when you give platelets when there's no actually need, it may actually form antibodies if we give it unnecessarily. And whatever you're going to give is going to disappear from the circulation quickly. So always remember to give it for an emergency, like when you're going for a surgical intervention. Otherwise, such a patient, you need not even give platelets. You can just wait on her with components, because that will be usually better. And suppose it's AFLP, how will you manage? Dr. Tenmuli?
Yes, madam. So if it is a AFLP patient, we have to manage her rigorously and plan for her termination as early as possible.
This patient is delivered, doctor. So that was this thing. So this delivered patient, how will you manage if it's AFLP?
And,
you have to do the same symptomatic
function,
therapy, fluids, glucose levels, because AFLP, they have more of
to be given interior.
And suppose she's gone into hepatic coma, how do you have got any patients with hepatic coma with acute fatty liver? Have you seen them?
Fatty liver we have not seen, madam, but first stage of liver failure we have seen. We have managed her rigorously with the lactulose, only symptomatic management, lactulose, vitamin K supplementation, and then the liver supplements like that.
Because when it's very severe, sometimes you may need to go for plasmapheresis actually. Sometimes plasmapheresis will be needed.
Yes, madam.
And very rarely, you have to go for like hemoperfusion and sometimes even liver transplants, but that will be at the end stage. It's so difficult to get, but people have managed acute fatty liver with plasma exchanges, and if not satisfactory, probably they have gone for even liver transplant. Our patient, we had to do a plasma exchange to bring her out of the problem actually. So acute fatty liver, and suppose it's worsening, like whatever you're giving, the patient is not recovering and she's becoming worse and worse. Remember that there's no instant cure after delivery, and this patient has actually developed the problem 13 days after her delivery. So always remember, postpartum period is also a very high risk condition, and sometimes a reverse trend has been seen. And we had one of our patients who kept on having thrombocytopenia even 15 days after her delivery. And the thrombocytopenia, we had to actually, she kept on having hematuria. So when we give platelets, she'll become fine. The next day again hematuria. So this patient also needed a plasmapheresis to bring out of the problem. And you have to keep, as one of the panelists said, a multi-specialty involvement is very, very important in such cases. What will be the differential diagnosis if it's not resolving at all? Like anybody would like to take that? Non-resolving help. Revati?
As you said that HUS,
HUS, TTP, and
catastrophic
CAPLA. And that's why, see, when a specialty team is there, they'll put all those ideas into your head. So at least you'll think of other problems which are happening. And remember that when there's no response to a medical treatment, and if she's not delivered and you've delivered her and still she's having these problems, it's going to be very difficult to manage. And that's why you need the support of a multi-specialty team. Remember that this patient had a bilirubin of more than 8. So it goes more towards acute fatty liver compared to HELP. Because HELP, it's not so much of liver damage. It's more basically the vascular system which gets damaged, and you have the microangiopathic hemolytic anemia. And that's why the jaundice happens. It never happens because of the liver damage. But in acute fatty liver, it's a liver which gets damaged. That's why the enzymes are massively elevated. And it's basically a consumptive coagulopathy in acute fatty liver. There it will be microangiopathic hemolytic anemia, and that is followed by DIC. And platelet function becomes problematic very fast in HELP, but it will happen later in acute fatty liver. It's more of bilirubin which is rising. Platelets will fall later when the coagulopathy starts, when the consumption of platelets is there. And remember, hypoglycemia is very common in acute fatty liver. You've seen patients dropping sugars to 30, 20, and they'll need glucose transfusion, glucose infusions again and again. Metabolic acidosis is a big problem in acute fatty liver. May not be seen so commonly in HELP syndrome. Increased ammonia and elevated serum. Actually, this patient had, when she regained consciousness, she seemed to be in a hepatic coma. She was talking irrelevantly for a long period of time. So we leaned towards acute fatty liver for her. And the other condition which you need to think about is thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. And TTP, it is more of it will be more of thrombocytopenia which is predominating. In hemolytic uremic syndrome, it will be the renal pathology which is very, very severe. The impairment is quite severe. The liver enzymes do not get elevated in hemolytic uremic syndrome. Similarly, in TTP, it's more of thrombocytopenia, and here it's more of uremia. There's no coagulopathy in these two conditions, and it's very common in the antenatal period TTP, whereas HUS is common in the postpartum period. And TTP is because of the marked reduction of the von Willebrand cleaving protease ADAMTS, whereas it's a toxin in hemolytic uremic syndrome, which causes a problem in the renal function, and it will cause a problem in the antenatal period. So anybody uses thromboelastography in coagulation failure in obstetrics to order your blood? Anybody has got the facility of TEG? If you have a cardiac unit or a liver unit attached to your center, it's a good thing that you have it, because you can always order according to what is lost. And when you put the blood in this instrument, it will tell you like which is a factor which is actually reduced and how much you can order. And there's something called a TEG act level, which is 80 to 140 seconds. And suppose it's increased, it means the extrinsic pathway has got activated. And R time is when both the pathways are activated, and K time is kinetic time, and tells you that the fibrinogen level is falling. Alpha angles tells you also the fibrinogen level. The mean amplitude tells us regarding the platelet function, and the lysin will tell you like whether it's fibrinolysis which is causing the problem, and they're just tranexamic acid will be quite helpful, and the Li30 is elevated. And these are the values which will guide you to ask for transfusions, because when the TEG act is more than 140, you should ask for FFP. When the R time is more than 10, you'll ask for FFP. K time more than 3 will be cryoprecipitate. If the alpha angle is a decrease, it will be cryoprecipitate with platelets. And when the mean amplitude is less than 50, it will be platelets you're ordering for. And Li30 of more than 3%, tranexamic acid you will order for. And the advantages is you'll have an immediate goal-oriented, individualized care for your patient. It will globally assess the coagulation function in the patient, including the cascade function and fibrinolysis. It's a point of care testing, and it will give you the treatment part also. It will diagnose coagulopathic bleeding. It will guide your transfusion therapy and decrease the use of unnecessary blood component therapy, which is very precious. And it will also detect dynamic changes. You'll get your report in the next 20 minutes, and that's going to guide therapy. It will predict the clinical efficiency of the agents you're using. And like aspirin, if it's been used, or if they're using heparin, and we'll know like how these drugs are causing the problem in the patient. And regarding the acute kidney injury, like how will you treat acute kidney injury? And because this patient had a renal impairment also. Dr. Tenmali, would you like to take that?
Yes, madam.
Yeah.
In case of acute kidney injury, we have to give her fluid restricted to 1 liter per day, and we have treat the cause of the acute kidney injury. If it is a septicemia, we have to calculate we have to go for higher antibiotics, and it has to be calculated depending upon her weight. And then we have to monitor her symptomatically, see for the electrolytes, daily electrolytes, and then urine albumin, etc.
Okay, yeah. Perfect. So you will treat her oliguria, giving her fluids, but restrict her fluid therapy, because when the renal damage is there, she can go for pulmonary edema if you hydrate her more. So be very careful. But if she's not responding, you can consider giving furosemide, Lasix after adequately hydrating, but never before that. But suppose she's oliguric, and when you're giving fluids, her oxygen saturation is falling, please remember it may be pulmonary edema. And then you cannot give a more of fluids, it will be diuresis, which will be the therapy. And if there's persistent kidney damage, it has to be managed according to this algorithm was put up in hypertension leading to AKI in critical care and obstetrics. And they have said, you do the renal function test, you do the electrolytes, as Dr. Tenmuli said, urine output chart should be maintained. The creatinine is less than 3, just monitoring and giving her adequate fluids correctly should be fine enough. But if the creatinine is more than 3, she will need dialysis. If there's hyperkalemia in her electrolyte report, she goes for dialysis. The urine output is more than 30 ml per hour, just maintain a chart and maintain her intake output. But if it's less than 30 ml per hour, she goes for dialysis. So this patient we admitted in the ICU, as the panelist said, we resuscitated her, gave her blood products and platelets whenever needed. Symptomatic it was actually, depending on the reports actually. And we gave her amikacin, photum, vancomycin and ufloxacin. 1 session of hemodialysis was done, but she kept on having episodes of bleeding diastasis, episodes of oliguria, had hemorrhagic infarct in the brain actually. She had persistent thrombocytopenia that we treated with intravenous immunoglobulin. She did not even need plasmapheresis, and she was discharged after a month. She came for her 4th delivery to me. She had no complications whatsoever, delivered her, and I did a tubectomy and sent her back. Unlucky for her, it was also a 4th girl. Thank you so much, Dr. Sneha. All the panelists, Dr. Revati, Dr. Tenmali, Dr. Kodai, Dr. Meena, Dr. Mary Jonava, Dr. Suhasini. Thank you so much for joining. I'd like to wish Dr. Sneha for her elections, Dr. Umayal for her election for chairperson. And thank you to the coordinators, Dr. Shobha and Anit. Thank you so much.
Thank you so much, Dr. Charmila. In fact, that was a very brainstorming discussion, I would say. And I just take this discussion ahead only a few cases. So today's panel is on near miss, and I welcome all the panelists, Dr. Revati, Dr. Tamil Kodai, Dr. Mary Genova, Dr. Tenmuri, and Dr. Meena and Dr. Suhasini. So friends, maternal mortality rate, these are not just numbers, rates and ratios. These are women, they have their faces, whom we have witnessed in the throes of agony, distress and despair. And these faces continue to haunt our dreams. It is said by Muhammad Fatullah, and looking back over the clinical times, one tend to forget or take it for granted one's success. And in fact, it is the failure which stands out like keloid scars, never to be forgotten by the person who has experienced, hopefully warning to others. So near miss is actually the terminology we have borrowed from airlines industry, and it tells you more correctly about the gravity of the situation and the urgency of intervention it demands. So it is actually defined as critically ill, pregnant or recently delivered woman who would have died had it not been that luck and the good care on her side. So in fact, analysis of such cases should actually improve the management by other obstetrician and gynecologists. In fact, it should be a learning lessons for others. That is why we are here, all of us, to face it. And as all of you will agree to me that in fact, over the last few decades, the critical care cases or the near miss cases, they have been on the rise considering the demographic changes. I will not go into the details. All of us are here to learn. Life is the best teacher, and we have to be the good disciple because life never stops teaching us, and we have to never stop learning. So with this, we straightway go to the first case. We have this for Dr. Meena. I think I start from you.
Yes,
we have this second gravida, previous season. The child is only 1.5 years old. She comes to you with history of 7 days overdue. Her UPT is positive, and she wants medical abortion. So you prescribed her the medical abortion pills, MTP pills, and instructed her, if at all any problem, you visit the hospital, and called her up for follow-up after 7 days. So she just had spotting on 1 or 2 occasions, but giddiness off and on. And suddenly on 6th day, 11 p.m., she was brought to your hospital by the relatives in a collapsed state. So Dr. Meena, what is your differential diagnosis for this patient and what investigations you would like to do?
When the patient come in collapse state, first thing come in my mind is that whether it was profuse bleeding, because of that she was collapsed.
Correct.
But as patient is giving history of only spotting, so being a obstetrician, the second thing comes in my mind is ectopic pregnancy. As during
Whether
that
it is
time
a
of
tubal
giving
ectopic or a scar ectopic, both are
scar
possible
ectopic.
because it is a previous seizure.
Third thing, that is incomplete abortion with torsion of ovary, or whether it is a corpus luteum cyst, hemorrhagic cyst rupture.
Okay.
These are all things come in my mind.
So how will you manage this case now?
First, we have to do an urgent investigation, and we have to replace the fluid, as it's a pallor was there, and it's a hypovolemic shock. And in urgent complete I will investigate for as a complete hemogram and basic all preoperative. As there is in my mind there is ectopic pregnancy. So first of all, I will put a probe and see whether there is a collection or not. If I see collection and there is a mass and there is no intrauterine sac, then the 99% diagnosis is going to go in favor of ectopic pregnancy. So I will manage according to that preoperative profile, and urgent call for anesthetist, urgent call for preparation of laparotomy.
So first, here I will like to interrupt you. So you have this patient who has come to you in a collapse state. So first of all, you will manage her intensively. You will try and resuscitate her first. By the time you will call your team for help, you will call the anesthetist and whosoever in your staff, you will call for help. You will put in 2 IV lines, start the IV fluids, and then you will send the investigations to the lab. By the time you will do some bedside investigation, so here you can do the hemoglobin, and here it's given it as 7 g/%. And of course, you said that you will do bedside ultrasound. That shows you ectopic pregnancy. So how do you go ahead with the management of this patient?
With investigation, I come to know it's a 7 g. I will arrange for blood, 2 pints of blood, and then prepare for her for laparotomy, as I am not a specialized for laparoscopy, and as there is no expertise here for laparoscopy. So I will prepare for laparotomy and go ahead with
You're right. The only treatment for this patient is surgical, because she's actually actively bleeding inside. So as long as you don't go for the specific management, you will not stop her from bleeding. So whatever amount of blood you are giving from outside, that will be a waste. So counseling, informed consent, prepare for surgery, and you take her for surgery. Meanwhile, the blood is getting ready. As very rightly you said that you are not expert at laparoscopy, so you'll prefer laparotomy. Somebody who is very expert in laparoscopy, even for ruptured ectopic pregnancy, they have been doing laparoscopic management very routinely. So whether it is a salpingectomy or a conservative surgery, that will be according to her parity and her will for the future fertility. So what are the learning lessons here, Dr. Meena? I would, in other words, I would ask you whether you should have gone for the ultrasonography, whether it is a must.
Yeah, it is a must before giving tablets.
By law, it is not must, but it is recommended. It is not a mandatory as far as the law is concerned, but it is recommended to be on the safer side for the patient as well as for the obstetrician, that we should go ahead with ultrasound before you give the empty pills, because it's a very early pregnancy. Clinically also, when you do internal examination, you will not be able to, appreciate whether it is an intrauterine pregnancy or there is some adnexal mass. So during early pregnancy, you may just miss this. That is what the learning lesson was. So
second thing is that we should go do her investigation also, blood group and at least basic hemogram we must do.
Yes, that is what we have already said, that the moment she comes to you, you
No,
aggressively start treating.
not before
You
giving
said-
MTP pill, yeah.
Yes,
Before giving MTP pill, we should
Yes.
know her blood group and basic hemogram.
That is a mandatory investigation.
Yeah.
For any sort of intervention you want to do with the patient's pregnancy, whether it is medical or surgical, the basic workup, that is complete blood count, blood group and RH type, and of course the tridot. All these investigations have to be done before any intervention. Okay. Maybe I would say even for the pregnancy at the very first point of contact. Okay. So well discussed, Dr. Meena. This
Thank you.
case. Now we go ahead with this second case, and I invite the second panelist here now. You have this 36-year-old woman who conceived after IUI. Her husband works in Dubai and she stays in a village. Once she conceives, she comes to you till 24 hours, 24 weeks. You do all her basic investigation. You find that everything is fine, and call her for regular follow-up, but she's missed out here. And at 34 weeks almost, she goes to a nearby PHC with the complaint of pedal edema. When the doctor examines, the blood pressure is 170, 110, and she's got pedal edema. So they advise admission, but she's not willing. So they just prescribe a tablet, nifedipine retard, 2 times a day. And now 2 days later, she comes to the district hospital with severe headache, upper abdominal pain. And when you examine, the blood pressure is 170 by 116. Her reflexes are brisk. And here again, only tablet labetalol was added. Magnesium sulfate, just intramuscular dose was given. And cesarean section was done at this district hospital. 1.8 kg female baby delivered. Her blood pressure always, in spite of these 2 drugs, remained between 140 to 180 systolic and 100 to 110 diastolic. And the patient was on nifedipine retard, tablet labetalol, and Maxelf continued. So almost around 20 hours after the cesarean section, the patient had severe cough, breathlessness, restlessness, her tachycardia, her blood pressure is 220 by 118, oxygen saturation falls to 70%, and her chest is full of adventitious sounds, wheeze. So Suhasini, what is your differential diagnosis here, and how will you manage this patient? So acute phase we will talk about first. Hello. Suhasini, yes.
Yes, ma'am.
What is your diagnosis first?
First differential diagnosis is acute pulmonary edema. Following
And it can
glance,
be pulmonary embolism also. You can keep it as
can
a
be
differential diagnosis. How will you manage? We have to be little quick. Be short.
Yes, ma'am.
Yeah.
Immediately she has to be on oxygen. I have to call for help with my anesthetist so that he will look after the airways, intubation of the patient, and immediate oxygenation of the patient.
Okay. What is pulmonary edema? What is the basic etiology? So that we go ahead with the management fast.
Yeah.
What is pulmonary edema?
This is because of the capillary endothelial leakage, which is causing the extravasation of the fluid into the alveoli.
Yes. So thereby what happens? There is hypoxemia, there is ventilation perfusion mismatch, there is increased work of breathing. Okay. So what else you will give in addition to the oxygenation?
Yeah. To reduce the edema, we have to give IV furosemide to reduce the edema.
What about the hypertension?
Yeah, to control the hypertension, we have to give the IV antihypertensives, labetalol.
Yes.
IV.
Yes. Any other panelists want to add something here? Dr. Revati?
Yes, ma'am.
Yes.
I think at this point we need to be aggressive One is, as Madam said, IV diuretic has to be started 40 milligram start once we are convinced that it's pulmonary edema. Then the next step would be aggressive antihypertensives. IV would be the first choice.
Yes.
IV labetalol would be the first choice. And like every 10 minutes, we need to check and we have to step up the dose, like from 20 milligram to 40 milligram, 80 milligram. If we are not convinced that IV labetalol is working, we should not think.
How much maximum do you give? And when you say that the labetalol is not working?
Up to 80 milligram we give, and after that we take an opinion from physician and start hydrolysid. The IV hydrolysid we give her, but maximum dose permitted for an acute episode 300 milligram
Yes.
can be given.
Yes. So you can give up to 300 milligram, but when you repeat 80 and 80, that is when you repeat 80 milligram, and that point of time when you don't find any desirable drop in blood pressure, that is a time when you take the physician's opinion or you change over your antihypertensive. Okay. What else?
And I think magnesium sulfate also initially, as per the history, it's only the IM loading dose that they've given. But I think IV, I mean, the complete regimen, Pritchard regimen.
Yes, later it is mentioned that it was continued for 24 hours. While shifting, they have given. Yes. So it is continued for 24 hours.
24 hours.
Okay. What else?
And based, we need to monitor, we need to catheterize her, monitor.
See, you can see here the blood pressure was 220 by 118, right? And the oxygen saturation has dropped down to 70%. So basically, you have to see whether the airway is patent, she's breathing on her own, or we need mechanical ventilation to be given to her. That is what we have to look for. And then, of course, antihypertensives. Again, we have to go for ABG analysis because she's got hypoxia, hypoxemia, she will go into acidosis. So to differentiate the diagnosis from pulmonary embolism to pulmonary edema, we have to go for chest X-ray, ECG, and of course the chemistry of cardiac enzymes as well, the coagulation study, because these are the conditions where, which lands up into the DIC, or what we say coagulation failure. So we have given her loop diuretic, as you have said, and of course the chest is full of adventitious sounds. So what do you give for that?
Okay. Nebulization is needed.
Yes. Steroids, assisted ventilation, we have talked about. Yes. Okay. So this patient was given, this patient was managed. Meanwhile, she was just, the moment you saw these readings at the saturation went to 70%, she was started on IV labetalol and Lasix also. But the meanwhile, when the patient was being managed, she collapsed and she had a cardiac arrest. So she was given CPR, she was put on ventilator. She was revived within 15 minutes and the blood pressure was that time 88 millimeter of mercury. The oxygen saturation comes to 90%. Now, after 1 hour, the patient is on spontaneous respiration. Her BP is maintained on 100 by 64. So I just want to ask you, Dr. Revati or Dr. Kodai, what went wrong for this patient right from the beginning of pregnancy, I would say. What were all the preventive measures we could have taken for this patient to prevent all this complication?
Maybe earlier, she came for a visit at 24 weeks and later at 34 weeks. Maybe earlier, we could have identified her pre-eclampsia. Now, when she presented
she was
to us,
regular till 24 weeks, I'm sorry. She was regular till 24 weeks. Could we have done the prediction considering the maternal characteristics, considering the, the uterine artery pulsatility index, and of course, various biophysical and biochemical markers? Because she was an elderly lady. She was IVF pregnancy, IUI pregnancy, so ART pregnancy. So whatever risk factors she had, we could have taken into consideration right from the beginning. We should have gone for scrupulous screening for PIH, right? So that we missed at that point of time. And when she reported for the first time with severe hypertension, that was the time that she should have been explained about the severity of the condition, and she should have been hospitalized at the higher center right at that point of time. And then, of course, the various factors, giving oral tablet labetalol or tablet nifedipine for such a severe hypertension. These were all the mistakes which were committed at each and every step where she was managed. So this was definitely a very, very preventable near miss, I would say. The patient was mismanaged at all levels. So we come to the third and the last case now. So Tamil Kodai, doctor, we have this case for you, 32-year-old para 1, previous cesarean section, male child, only 1 year old. She came to you as bleeding per vaginum, and this was her first visit during 6 months to your place because of the transferable job of the husband. She was registered at some other city. And on further inquiry, she gives you history of spotting during early pregnancy. The ultrasound was showing low-lying placenta then. So when you do her ultrasound at this point of time, it showed placenta previa with absent RP leg, and the anomaly scan was no abnormality detected here. So when she comes to you at 30 weeks again, she gives you history of bleeding, which stopped while she reached the hospital. But 10 days later, she was brought to you in a collapse state. So what is the diagnosis? How do you manage this patient at this point? And again, I make the same question. What were all the things gone wrong, and at what stage could it have been prevented?
Yes, ma'am. This is a case of antepartum hemorrhage. She had placenta previa. At 30 weeks of pregnancy, she was brought to us with a collapsed state. No, so
30 weeks she stopped bleeding. She started bleeding and stopped when
after 10 days.
Yeah,
10
days
after
later
30
again.
weeks
So
of
almost
pregnancy,
32
she was again brought to us with the collapsed state.
Yeah.
Okay, ma'am. So what is at that time when she was getting admitted, we should do the resuscitation first, and we should know whether it is a coexisting abruption should be ruled out. At the same, then if it is a placenta percreta and bleeding profusely, we should terminate the pregnancy at that
What
time.
difference it will make to our management if whether it was a placenta previa or abruptio with when she is in a collapse state?
When she is in a collapsed state, when she is having a placenta previa and bleeding PV or an abruption. Abruption means coexisting coagulopathy is very worsening condition to be associated with. So at that time we need other products, blood and blood products should be at hand. For both the situations we need blood, but for abruption
it's not
we need
necessary
other
for this patient. What is the diagnosis of this patient?
Diagnosis is previously it is placenta previa, so might be this placenta previa with painless bleeding PV. She might be having history of profuse bleeding PV should be asked for this patient.
So we can have Dr. Marizinova. Is she there?
Madam, she has got some emergency call, madam.
Okay. So we again come back to, I think, you, Dr. Revati, and then again to Dr. Meena. What is the diagnosis of this patient? Let us first come to that consensus. Let us first agree on this.
Yes, ma'am. As diagnosed earlier, it is placenta previa, and now she is brought in collapse state. Maybe she had bled at home, and now she's in a hypovolemic, hemorrhagic hypovolemic shock. So our initial, leaving aside the diagnosis, I think initial resuscitation starts first.
Yes.
So
that is what the point I want to make it clear at this point of time, that whether she is bleeding because of placenta previa or abruptio, we have to aggressively resuscitate her first, put in 2 IV cannulas and send the blood, and then you call for help, and of course then now you go for diagnosis and further
obstetric
management.
diagnosis comes next.
But do you have her diagnosis here in the history? You have ultrasonography at 26 weeks, which is saying absent retroplacental leg.
Yes. It
It's
suggests
there.
a placenta accreta.
It is placenta previa accreta.
Accreta. Yeah.
Okay. It is placenta previa accreta. The absence of the retroplacental zone, or you say the retroplacental sonolucent zone, gives you a clear-cut diagnosis of placenta previa accreta. She is bleeding. That means it is not completely accreta, but yes, there may be patchy adherence. Okay. Now we come to the management once again. Yes, Dr. Revati and Dr. Kodai.
Yes, ma'am. We need to secure the IV line. Green cannula, we need to secure an IV fluid resuscitation starts first. Once we are done with the blood grouping and typing, and then we order for the blood, and blood transfusion also starts. Meanwhile, we need to make sure that her cardiopulmonary status is stable. Her
The patient has come to you right from 26 weeks. So naturally, she has all her investigations with her, blood group, etc. Okay.
So,
First
we
and
need to
foremost, you
order
order for blood and blood products, definitely.
Till then, crystalloid resuscitation, we start her on crystalloids, RL or NS, we start her on crystalloids. Meanwhile, we need to make arrangements to start the packed blood cell or whatever, based on the local protocol, whatever we get the first.
Okay. Keep at least few blood and blood components ready, whatever possible, because the baby is also alive. So we have to go for emergency cesarean section at the earliest. Now we come to the problem. Whether it should be a cesarean section alone, or it should be a cesarean hysterectomy or obstetric hysterectomy.
For this particular case, it should be, as Madam Shashi Madam showed previous video, I think this case is quite similar to that. I think following the delivery of the baby, cesarean hysterectomy would be more ideal, but it should be an intraoperative. We would have made a diagnosis earlier, but still
the evidence says that if you have a diagnosed placenta previa accreta, in fact, what you do is you do a placental mapping. Your incision should be, so we'll come to the what precautions you have to take for surgery. But here, in fact, they have suggested that it should be a planned obstetric hysterectomy. It shouldn't be an emergency hysterectomy. Now, this is an emergency cesarean section. That is why we will say it as, okay, we have to take the consent or informed consent for cesarean section along with hysterectomy, right? Otherwise, what is the management? Can somebody talk on this? If there is any difference of opinion, please justify.
Better to operate this case in a multi-specialty hospital.
That is tertiary care center. What about the hysterectomy? There is a consensus that if in such a case, basically it's a very clear-cut suggestions that right from the beginning, if you discuss this case, when the moment you go to the history first, the moment you diagnose it as placenta previa accreta, here it is said that, early pregnancy spotting. Then you have 26 weeks. Again, she has spotting bleeding. And again, 30 weeks. So the moment you diagnose placenta previa at 26 weeks, that is a time when you have diagnosed placenta previa accreta. And this is a time where you have to actually hospitalize this patient because she is having repeated warning hemorrhages, right? And you have to explain the patient and the relatives the prognosis of this pregnancy, the outcome of this pregnancy. Anytime she can land up into profuse bleeding, and anytime we have to take her for emergency cesarean section. Though our aim should be to prolong the pregnancy till 34 weeks at least. Meanwhile, you give steroids and give magnesium sulfate for baby's neuroprotection. So that is how the management is. And when you go for when you take a decision for whether elective surgery or emergency surgery, we have to make sure that at least the senior obstetrician, senior anesthetist is around, and you have ample blood and blood products available at your disposal. And then, of course, you have to have the informed consent regarding the obstetric hysterectomy. You have to explain the relatives that she can land up into massive hemorrhage and she may require massive transfusion, and massive transfusion protocol also may be initiated for her. And all possible complications have to be explained to the patient and the relative relatives, then only we can go ahead with the surgery. So now this patient landed up into emergency. So we have to go for emergency cesarean section with the obstetric hysterectomy. Here, in fact, what precautions are suggested, that you have to take a incision which should be liberal. You have seen Dr. Shashi has shown the video, because in such cases the incision has to be liberal, because you need to go for manipulations, and you have to take an incision on the uterus which should be vertical midline, or some people say it should be transpondal, because you should not cut or incise the placenta. And once you remove the baby, there should be absolutely no attempt for separation of the placenta. That is what is recommended. And in fact, you have to remove the uterus with the placenta in situ. So that otherwise, if you try and go for removal of the placenta, she will bleed torrentially, and the stable patient will worsen under your observation. So that is how all the precautions you have to take. Here, in fact, they have said that in addition to the obstetrician, anesthetist, physician, neonatologist, you should have some interventional radiologist. If at all the uterine artery embolization can be done, maybe a oncosurgeon or a urosurgeon, where the stenting of the ureter, sometimes, you know, you may have not only accreta, but increta or percreta may also be that you will come to know intraoperatively as well. So now the question here is whether this was preventable, whether you could have given you could have given a cervical stitch for this patient. Was there any role of tocolysis? So I think Dr. Kodai, you can take up this.
Yes, ma'am, it is a really preventable one. And we should have, patient had a history of bleeding PV many times, and she approached the obstetrician. So should have been admitted before itself. That is the first thing.
Yeah.
And then cervical stitch for this patient, I don't think it is very useful for this
Please say that. Please say that. That is a message we want to give, that there is absolutely no role for prophylactic os tightening, especially in this case of placenta previa, when the placenta is lying low lying. In fact, there is a specific indication for os tightening, that is the cervical length of less than 2 centimeters. Then only you have to go for os tightening, and not when the placenta is low lying. Any role of tocolysis?
Tocolysis also, there is no role.
Correct. You are right. So let us see what RCOG green top guidelines say, that when you do go for, you know, the anomaly scan, mid-trimester anomaly scan, that is a time, in fact, where you have to locate the placenta, especially look for the retroplacental space, whether it is present or absent. So when you do ultrasound at 16 weeks, and when you find it is less than 2 centimeters away from the os, that point of time you have to label it as low-lying placenta. But later on, when it still persists the same position, you have to label it as placenta previa. Transvaginal ultrasonography is always better for confirmation of the diagnosis, unless the lady is severely obese or the placenta is posterior. Maybe in that cases where you need to go for MRI. Cervical length measurement should be done here itself, 11 to 13 weeks or 18 to 22 weeks, so that, you know, that gives you an idea whether this patient is likely to go into preterm labor. Because when she goes into preterm labor, this formation of lower uterine segment, and that is a point where she may start bleeding, and so that you should be ready for that. So prophylactic os tightening per se has no role. Tocolysis not indicated, and there is no significant benefits in the management of placenta previa as far as these points are concerned. So we have to confirm that the placenta previa is placenta previa accreta, and as we have discussed, we have to pull this pregnancy till 34 weeks at least, prepare the fetus and go for elective surgery. As I have told you that all these special precautions during the surgery has to be taken, where I have already explained it previously. So the same thing, and that is how I think it should have been managed. So it was totally a preventable near miss. So Dr. Charmila has very well discussed with you all the transfusion protocol. So I would like to not to discuss or repeat it again. So in a short span of time, I think we have covered quite a few cases, and these are the routinely encountered cases. I think the preventable problems naturally. We obstetricians can meet these kind of cases anytime, and that's the reason I think this will be helpful for majority of these obstetrician. I would just share my screen just for a moment, and I'll just say few points to remember that whenever you are trying to resuscitate the patient, it's not only the volume we have to transfuse, but sometimes, when the patient has hypovolemia or hypovolemic shock, you need whole blood. When the patient volume is good, but she needs to improve her oxygen carrying capacity, that is a case where you have to go for packed cell. And of course, the when you have the various blood components like platelets, sometimes you have thrombocytopenia. So as very well discussed here, if she has already delivered and there is absolutely no intervention now and she's not bleeding, so even 20,000 she's safe level at which she can be maintained. But when you're planning some intervention or operative procedure, then at least 50,000, or maybe all these parameters which gives you the coagulation profile, as right from the intrinsic pathway, extrinsic pathway, all these parameters have to be in a proper proportion. That appropriate parameters have to be there in appropriate proportion. That you have to remember. FFP, that is a 240 ml pack, and usually you need 5 units. We have discussed 5 units of FFP and cryoprecipitate. 10 bags gives you only 75% of the fibrinogen, and it increases the factor 8 by 30%. So this is how we know how it is available. And of course, if Dr. Mary Genoa is not there, and that's the reason I cut short the last case here. We actually had very good case of diabetic ketoacidosis. So I will just give you the message that we had this grand multipara with a large baby and obstructed labor. She landed up into obstructed labor with fetal distress, and she was taken for cesarean section, operated uneventfully, but suddenly she went into shock. There was absolutely no blood loss, significant blood loss, I would say, and everything was apparently well, and she suddenly collapsed. Non-hemorrhagic shock, we would say. So the bedside investigation saved her. Her blood sugar was more than around 600. And that is how she was diagnosed. The urine sugar was 3+, ketones were 2+. So she was diagnosed as having severe diabetes with ketoacidosis. And then, of course, the routine management done by the physician, aggressive management, and the electrolyte imbalance was also treated. Only thing is, the message I want to give here is universal screening for diabetes is the key to success. We could have avoided this catastrophe. Every woman during every pregnancy should be screened for gestational diabetes or hyperglycemia of pregnancy, and she should be screened at the very first point of antenatal contact by the single step 75-gram glucose testing. And if that point of time she is negative, then we have to repeat it at 24 to 28 weeks, and again, if time permits, 34 to 36 weeks. That is how we could have avoided, we could have diagnosed and avoided this catastrophe. So every obstetric unit and every person who works in the team should be trained and skilled to manage the maternal collapse. No time for immediate referral. We have to resuscitate the patient, stabilize, and then send to the ICU or obstetric HDU. A referral in unsettled case may worsen the situation due to multiple issues. So the team should manage effectively, and then and there only. For this, we should have efficient multidisciplinary team, not only HDU. So with this, I thank all of you for your excellent contribution, and I request your blessings, your wholehearted support for my candidature as Vice President Foxy from West Zone. West Zone has got 2 posts. So in addition to me, you have one more choice for Vice President Foxy. So the elections are from 1st to 10th August and they're online. It will take only 2 minutes of your valuable time. So I request all of you to bless me and vote for me. Thank you so much.
Thank you, madam. Thank you.
Once again, I thank all of you and I thank Dr. Shobhana and Anik for the coordination, and I thank Dr. Umayal for being the excellent convener as usual. I wish her all the best for her elections as well. Thank you so much.
Thank you, madam. Thank you, madam.